All right, hello everybody. It's your boy Saiken MD here with some internal medicine board review. Today I am joined by JF. JF MD, if you want to introduce yourself, go ahead.
Sure. Hi, everybody. My name is JFMD, but I go by JF. I'm your medicinal plant dragon VTuber, question mark. But I'm also an internal medicine doctor, just like Mr. MD, Psych and MD.
Yeah, so I just randomly thought it would be really funny because the residents that I'm working with right now are preparing for their boards in August August, whenever they take it. And JF and I both actually finished internal medicine residency last year. We didn't go to the same program, but we studied the same specialty. So we are exactly 1 year out from boards, but I was able to get one of the residents' login information, and I was like, hey, can I fuck around this with my friend? And he was like, sure, I guess. So I have a board review question pack, and we'll see if two internal medicine doctors that are a year out from studying for the exam can actually do well on these. I'm sure we'll pass, but do well is the grand thing here.
Yeah, I'm sure we'll do fine.
All right. I technically have a video on this already, but do you wanna explain internal medicine in your own words? Because I know a lot of people get tripped up when they hear about internal medicine and they're just like, what kind of specialty is that? Like, does it imply the existence of external medicine? Does it blah 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 blah?
Yeah, it's a great question because what is internal medicine? What's medicine in general? I feel like we don't really do a great job of explaining that to people in general, but even to people who are interested in medicine. So internal medicine, I guess one way to think about it is we primarily take care of adults, right? So there's one big branch point between kids and adults, right? Pediatrics and the adult world. And we don't really take care of kids. That's unfortunately straight out of our wheelhouse there. But most other things in the adult world we do take care of, right? And as the name implies, it's really just things that are inside of the body, which is not very helpful because there's a lot inside of your body, but it can include all different organ systems, your heart, your lungs, your liver, your gastrointestinal tract for those people who like that, and everything in between. Of course, there are also generalists too, like Saiken and I, who are on two opposite sides of a coin, but we're generalists in the sense that we kind of take care of pretty much everything that comes to mind when it comes to medicine for someone who comes in front of us. And between the two of us, it's either in the hospital or out, but there's always many different parts of medicine that we take care of for the adult side, and we see it all.
Yeah, so JF and I are like two sides of the same coin, basically, because he is a PCP, a primary care provider. So he works in the outpatient setting in the clinic, whereas I'm a hospitalist, so I work in the acute care setting in the hospital. So the acuity of our patients kind of spans the whole realm of office-based medicine to hospital-based medicine. And I feel like our expertise combined really adds up to something substantial, because the exam is also about office-based care and hospital-based care, because internal medicine really can choose to do either of those things. So yeah, let's get started with undisclosed, nondescript board review questions.
Totally legal, by the way.
Sponsored by one of the PGY3 residents that I'm working with. I hope he does well on boards. Certainly better than us.
Oh yeah, 100%.
Right. I guess I'll start with the first one. A 20-year-old woman is brought to the emergency department from a college dorm. She attended a party earlier that night and was brought back to her room by her roommate. The roommate told paramedics that she called for an ambulance because the patient was agitated, combative, and confused, and then appeared to have a seizure. The patient was obtunded by the time the paramedics arrived. She has a history of psychosis and takes risperidone and diphenhydramine nightly. All right, so now the fact that I've read this, I realized that we actually already did this before the stream because I was trying to see if the formatting was correct and everything. But all right. Anyway, we already have the answer done. I'm sorry. But when I'm talking through the questions, basically the biggest thing in a board question is the question stem. There are only so many different ways that the exam can ask about different conditions that it's really important to see what the actual question stem is saying. Every piece of information that they give you is important for a reason, and every negative piece of information that they put in there is also important too, because they either make things extremely obvious for uncommon things, extremely uncommon for common things, or common for common things. There's usually not going to be like a super rare presentation of a super rare thing, but yeah. So, emergency department from a college dorm, you're thinking of a 20-year-old. They were at a party earlier that night and there was like an acute mental status change, right? She became agitative, combative, confused, and appeared to have a seizure. So I'm worried about like acute intoxication, what kind of drugs, what kind of drugs could do these things, right? So agitation, combative, confused, you're thinking stimulants, you're thinking things like, in terms of drugs, you're thinking of things like Molly, PCP, maybe even acid, right? And what am I finding important here is that the patient also has a history of psychosis and takes risperidone and diphenhydramine nightly. So the patient already is on an antipsychotic and taking a antihistamine every day. And on top of that, they are taking substances at this party that is leaving them agitative, combative, and confused. So I've already kind of got a differential going on there, like thinking about different things that could be happening at this college party. So now I'm going to approach the physical exam and the vital signs with, this in mind. So temperature is 103 degrees Fahrenheit. Blood pressure is 179 over 108. Pulse is 135. Respirations are 24. Physical exam shows a young diaphoretic woman who is warm to the touch. Pupils are dilated. There's no nystagmus. Occasional tremors are noted, and she is hyperreflexic. So, when you see these things, what's screaming out to me is, yes, her blood pressure is very high, her pulse is very high, her respirations are very high, but also the fact that she's extremely febrile. She's got a 103 fever, right? And she's sweating, and her pupils are dilated. So, yeah, somebody in the chat already got it. This kind of is, pointing more towards something like serotonin syndrome, or what's the other one called? NEMS, like neuromalignant. What's it? NMS? What does it stand for?
Yeah, NMS, exactly. Yeah, neuroleptic malignant syndrome.
Neuroleptic malignant. Yeah. So basically, you're thinking of like your body overloading, overheating. The on switch is constantly on. The hyperreflexia there being that like you try to elicit their knee-jerk reflex and their knee basically just shoots out immediately. So is it like a stimulant medication but not MDMA, because wouldn't that cause nystagmus, right? So now you're thinking what drugs can cause things like serotonin syndrome or NMS, and also what drugs would interact with the patient's normal medications that could cause this presentation as well. So here I'm going through, the labs. So they're hyponatremic, bicarb is 28, BUN is 38, creatinine is 0.8. They've got some transaminitis going on. Their INR, their liver and their clotting factors aren't doing too well, and their CK is high, probably because, their limbs are essentially going super ballistic, and also probably like cramping and digesting its own muscle tissue. So yeah, we got to the answer choices here. So which of the following is most likely ingestion causing the patient's findings? So we've got 3,4-methylene dioxymethamphetamine, we've got diphenhydramine, we've got phencyclidine, we've got psilocybin, and we got risperidone. So I thought it was MDMA, because it's causing a serotonin syndrome for the patient, which for me, I was thinking more on the hyperreflexia angle and the new fever, and I ended up getting that one right. So I don't know. Do you want to read like the explanation? Then we don't have to do like the individual answer choices, but we can talk about like why these things do these things, and then what is relevant for our like clinical practice.
Yeah, and I think just to kind of go back to what people might be more familiar with, on your stream, Saiken, is that there's a big difference between the questions like these and doctoral, right? Where you can tell like this is like a multi-layer question. Like you can tell, okay, maybe something is up with an ingestion, some kind of recreational drug or something from the start. But the question itself is even trying to push that further and say, well, it doesn't exactly fit any toxidrome for a particular drug, right? I think someone in chat was talking about how there's no nice agonist, so it doesn't sound like it's Molly, but that's where the question tries to get you. It's not because of a drug itself, right? It's like what happens from ingesting the drug, that serotonin syndrome afterwards, which Molly's not the only thing that can cause serotonin syndrome, right? Other things can too, but it's kind of recognizing that additional step after. That's the level that these questions are at, because it's not just like, boom, I've got one drug, that's the flashcard on one side, the other side is, oh, this is what it is, right? You got to recognize that the drug is responsible for the syndrome, and then the syndrome then does this. It's like multiple steps, and that's how these questions are. Most of these questions are of these level, because when you get to this point, you have to like take into account the entire situation. It's not just one thing in isolation. That's honestly a lot closer to what medicine is in practice, because one person's just not one like textbook question. They've got a lot of different things, and can be the thing they had for dinner 3 nights ago or something. You have to take everything into account when you do a good history and a good exam, as well as kind of what testing you want. All of that has to be factored in. So I thought that was interesting to look into as a different perspective compared to what we're usually used to, where it's like a series of, oh, what's this next hint on the dot turtle? It's just an entirely different perspective.
Yeah, if you watch medical TV shows like House or whatever, like they always do the thing called the differential, right? So the differential diagnosis is the process where the doctors are going through the very many possibilities that could be, what's the patient is presenting with, and trying to narrow it down, but also ruling out why it's not the other things. At this point in your training, right, when you've gone through med school, you've gone through residency, like, yeah, the correct answer is probably screaming at you. And, if you do medicine like that and treat patients based on probablys, like, yeah, you'll probably get like 85% of the correct diagnoses on the first try. But, when you're actually working, right, when lives are at stake, when the medical legal implications of your license are at stake, right? It's not just enough to make sure that it is the thing that you think it is. You need to logically make sure that you're ruling out why it's not the other things that could also present like it. So, yeah, I'm here. Serotonin syndrome secondary to MDMA. I like that. The rhabdomyolysis, the hyperreflexia. Was it for me? I guess I kind of glazed over the hyponatremia, but yeah. So the patient was like taking a bunch of MDMA, dancing a lot, being at a super crowded party, trying to just get as much water into their system as they could, and they got super hypotonic from that. But yeah, like everything on the labs that they give you, like in the board question, is going to add up. So just test taking tips in general over there is pretty helpful. Like sometimes you're not going to get it based on the question stem, but when you actually start looking at the rest of the data that they give you, you're going to be in a good position to like get the correct answer. Unless you're like me and then you start overthinking and you're like, oh, well, this doesn't actually add up with what I thought it would be.
Don't worry, you're not the only person who does that.
And then you end up spending like 10 minutes on the question and then you don't have enough time.
I swear they do that on purpose. They're like, oh, we're gonna get this doctor by making them overthink all these answers. 100%.
Yeah, like isn't overthinking a good thing? Like, doesn't it show that we're thorough? Like, I think some of the things that I hate about just like everything in this path from like the SAT to the MCAT to STEP, like it's always multiple choice, right? Like it's hard to like show your thinking, and there's no partial credit for anything.
Oh, what's a great idea? You should do the cases for step 3 as a stream.
I was gonna do that with Shiori.
Oh, that's a great idea.
Oh, I got a raid from Kofi. Hello Kofi channel. Hello friends. Yeah, what's up? My name is Saiken MD. I'm an internal medicine Dr. VTuber. Today we're doing internal medicine board review with JF MD, who is also a internal medicine doctor, soon to be Dr. VTuber.
Hello.
All right. Okay, we haven't done this one. You want to do this one?
Yeah. Let's do this. All right. So A 35-year-old man comes to the office due to bloating, excessive flatus, which is having too much gas, and loose stools since an episode of food poisoning several months ago. This is me. This is what I see, for example, tomorrow afternoon in urgent care. Uh-oh, a cruise ship is involved. This is
Oh.
very topical. The patient had been on a cruise ship when he developed nausea, vomiting, and diarrhea. Uh-oh. Several other patrons developed similar symptoms that resolved with supportive care only, which is like fluids and rest, but no real medicine required. The patient's current symptoms began 1 to 2 weeks after returning home and usually occur in the morning shortly after breakfast, so with food. His usual breakfast consists of coffee with whole milk and cereal or oatmeal. It's a pretty good breakfast. Yeah. Soon after eating, he develops bloating, followed by crampy abdominal pain and loose stools. The symptoms occasionally recur after dinner. Oh, but what's he having for dinner? They don't say. Medical
He's
history
having
is
milk and cheese.
I bet. Medical history is insignificant. The patient drinks 1 or 2 beers on weekends and does not use tobacco or illicit drugs. He reports no other recent travel outside the country or unusual food exposures. So Saiken's doing a great job of doing what we would do in an actual exam, highlighting the very relevant points here. So looking at this, it definitely sounds like there's something going on system-wise. It's the gastrointestinal system, of course. There's gas, there's stool, there's bloating. What else could possibly be? But specifically what's going on with the gastrointestinal system, we think about the age, we think about the exposures, and we think about the symptoms that someone's having in the time frame, right? This is a relatively young gentleman, so we think of some of the older things that might be more relevant there. Probably won't be as applicable to this guy. On the other side, right, there are some conditions that are more common in younger people. For example, inflammatory bowel disease or other forms of autoimmune and intestinal diseases that are more common in younger people than in older people, just because what we think of the causes is like a stronger immune system can lead to an overactivity, and that's what actually causes autoimmunity, right? So 35-year-old man, their immune system probably is very robust versus like an 80-year-old gentleman. In addition, these symptoms have been going on for about a couple of weeks and on and off, and they seem to be associated with some particular exposures. In this case, right after breakfast, and they conveniently tell us what their breakfast is: coffee with whole milk, cereal, or oatmeal, as well as dinner too. But it sounds like it's related to food and associated with loose stools and bloating. No medical history, right? So there's nothing to suggest that this was something that occurred in the past either, as far as we could tell. And in terms of the social history, other recreational substances, alcohol, smoking, really just what sounds like social alcohol use and nothing else. So nothing else there. With that in mind, then we think about the exam. What do we expect to see doing the exam, focusing specifically on the abdomen, right? Taking a listen, doing palpation or pushing down to see if that elicits pain. And it looks like vital signs are normal. So for most other things, there's something more serious going on that we can tell. The abdomen is soft and non-tender. So as far as we could tell today in the office, right? Because not everything happens when you go to the doctor's office. Sometimes you're like, oh, I should probably make an appointment to see the doctor. and then you feel better and you're like,
yeah.
Sorry, doc, I guess it's gone. You scared it away. It happens all the time when I see people in clinic. Bowel sounds are present with loud borborygmi. That's a great word for the gurgling you hear when you hear your stomach rumble. That's what doctors have to call it because we have to be very fancy.
I just say bowel sounds.
Yeah, me too.
I mean,
me too.
like, yeah, I think technically borborygmi is more like from like the stomach or something, but just like, I don't know. I feel like if you say borborygmi, like you're either outing yourself as like a gastroenterologist or like a med student. Like nobody.
No offense to the med students, okay? It's totally okay. But yeah, I also just say bowel sounds. There's no need to be fancy. And no hepatomegaly or splenomegaly, right? That's just fancy words to describe that the liver and the spleen are also not swollen at all, which can be signs of either failure, infection, or something going on there. So things seem to be pretty normal on our exam, besides the loud sounds. So then we think about what tests to do, right? Or if we would even do tests. And I'm going to be honest with you, if I saw this patient in my clinic, I don't know if I would do testing. And the reason why is testing costs money for most people, at least in the US, right? Number one healthcare system in the world, slash us. But, you know, it takes money, it takes time, and there's also the consideration of false positives. Like, what happens if the test comes back and it says, oh, something is wrong? Does that actually line up with what you suspect as a doctor, or could it be a red herring, right? That's important, because if I then call the patient and I'm like, this test shows that you might have cancer in this 35-year-old, right? Is that likely or not? It kind of goes into how we build up our differential, like Saiken was talking about. So,
And it
you know,
also
if a
goes into
differential,
specificity and sensitivity and
yeah,
positive predictive value and negative predictive value, but
all
we
of
can
those things, all the things that you learn in medical school and residency and beyond, the math never goes away, I'm sorry to say. Um, but, you know, what we think about here, for example, is the most likely differential on my differential diagnosis, the most likely thing that I think it might be is probably something that's pretty mild, right? And if I want to commit this person to a whole workup, and you can see here the question here is, what should we do? What should we do to test, or should we even do any testing? Should we skip the testing and just try something? What should we do, right? And you may have been in a situation with your doctor in clinic where you might be thinking, well, man, my doctor didn't order any tests. What are they thinking? Do they just know what it is, or are they not going to bother with any testing? Why is that? And sometimes the testing isn't worth it. It's not worth what we're looking for, and it might not even be helpful to tell us what we're looking for. So I think that, you know, some of these answers can be right in a textbook setting, right? They can get you what you're looking for, but is it the best option here for the person who's sitting right in front of you in the office? Or is it going to be unnecessary? That's kind of another facet of these questions, where it's not just what's right on the flashcard, it's what should we do for this person that's the best for them. It's complicated, right? Best is a very tough term. So we order some basic tests, my bread and butter basic tests: blood count, chemistry is like a metabolic panel, thyroid testing, and inflammatory markers and infectious testing. All are absolutely normal. So even more reassurance that this is not a big, serious issue. So I went on a long-winded talk about how we do differential diagnoses and how we actually test things in the clinic, because it's something that, you know, doctors don't do a good job of explaining in the clinic. I'm also not entirely free from this, because if I have 15 minutes to talk to you, am I going to spend the entire 15 minutes that I just did talking to you about why this is not the best choice? Or am I just going to say, no, we're good, and call it at that? There's always the time constraints, right? But, you know, even just by talking about this, kind of a sense of what it was. And the clue here is that it comes after meals, and the meals he has usually have milk in them, right? And what can happen, especially after a recent infection, which he probably got at the cruise ship because other people around him also got that, usually as a clue for infection, is that people might be more sensitive to milk products, what we call lactose intolerance. And so then what should we do here, right? Should we do a stool sample or a fecal fat collection for 72 hours? I would never subject anyone to that. That's like a 3-day collector of poop from the toilet. Never would want to do that. Or should we simply just say, D, let's give a try holding off on having anything that's dairy related and see how you feel. I feel like that's probably the least maintenance, and it could give you the answer right away. Probably what I would do first.
Yeah, I agree. I have zero complaints with recommending a trial of dietary lactose avoidance. Very funny how last week I just made a video on lactose intolerance. But yeah, so if you watched the video, if you didn't watch the video, just quick review, right? So lactose is a molecule that's found in a lot of dairy products, and it's a complex sugar that is two individual single sugars stuck together, so a glucose and a galactose. And most people, you know, most humans are able to cleave lactose into glucose and galactose, and we're able to absorb those sugars normally. But for some people who are lactose intolerant, they lack enough, or they lack totally, that lactase enzyme, so they can't cleave the lactose molecule into glucose and galactose. And when that happens, the whole lactose molecule ends up making its way down the digestive tract without being absorbed, without being cleaved, and the bacteria, your gut bacteria in your colon, are going to be like, oh cool, lactose, let's ferment this. Let's treat it like how I know how to treat sugars, and eat it and start pooping out a bunch of CO2 and oxygen and start giving this guy a bunch of gas. So I'm pretty sure we're correct. I'm just gonna hit it here. That's pretty much what's happening here.
There
Right.
we
So
go.
he had a recent inflammatory bowel illness, and that probably messed up his the terminal villi or whatever, and that messed up his intestines. So I think somebody was saying that, like, oh, lactose intolerance, but it wouldn't be this long, since the cruise. But apparently, it can take several months for it to come back. So his cruise was several months ago, and he's still having problems with digesting lactose, and he's still having coffee and whole milk with cereal and oatmeal and all those things. So yeah, easiest way is just, see if you can tolerate a lactose-free diet, and then over the next couple of months, like, start slowly reintroducing it. Cool.
There you go.
All right. 68-year-old woman is admitted to the hospital due to shortness of breath and lower extremity swelling for the past 6 weeks. Her medical history includes hypertension, which is high blood pressure, hypothyroidism, which is low thyroid function, type 2 diabetes, hyperlipidemia, which is high cholesterol, obstructive sleep apnea, and stage 2 chronic kidney disease. The patient had a transient ischemic attack, so kind of like a mini stroke, with a right carotid endarterectomy 8 years ago. So the vascular surgeon went in and basically cleaned out her carotid artery of all of those cholesterol plaques. Home medications include aspirin, levothyroxine, hydrochlorothiazide, which is a diuretic, lisinopril, which is an ACE inhibitor, atorvastatin, which is a cholesterol medicine, and glipizide, which is a diabetic medication. She has never used tobacco. All right, so we've got shortness of breath and lower extremity swelling. So these sorts of things, you're worried about a fluid overloaded state. Definitely something that happens quite often in heart disease, right? Your heart is a pump, and if things aren't pumping forward, things are going to start backing up. And what's right behind the heart? The lungs. Right? Behind the lungs is the right side of the heart, and behind the right side of the heart is the rest of your body, right? So if your fluids aren't going forward correctly, these things are going to start backing up, they're going to start third spacing, they're going to start depositing in the rest of your interstitial spaces. Like, oh, whoa, somebody spelled edema with an O? That's not very American of you. Oh, edema?
Oh, edema.
Didn't I confirm on Twitter a few months ago that like British people say GERD as gourd because it's it's gastroesophageal reflux disease.
That's wild.
Right.
I think that was what people said.
Anyway, so I'm thinking of a fluid overloaded state, right? I'm seeing some people saying heart failure, HFpEF, so heart failure with preserved ejection fraction, and she is on a bunch of medications already. Is third spacing a medical term? Yeah, it is. It is third spacing. I mean, that's what I call it. All right. Temperature is 99 degrees Fahrenheit. Blood pressure is 122/80. Pulse is 84, and respirations are 22 a minute. So, I mean, she's afebrile. Her blood pressure is pretty good. Her pulse is fine, but respirations, I mean, she is breathing pretty quickly. Right? Pulse oximetry is 92% on 3 liters oxygen via nasal cannula, which means that probably at baseline without it, her pulse ox is probably 80, 87, 80, 86, which is not great. So she's needing 3 liters of oxygen being delivered through that nasal cannula in order to keep her sats up. JVP is elevated at 12. Lung examination reveals decreased breath sounds at the bases with bibasilar rails up to the lower 1/3 of the chest. So basically, she's got crackles in the lungs, and you're going to be associating that with the fluid overloaded state. Cardiac examination reveals a normal S1 and S2 and an audible S4 over the cardiac apex. So with heart sounds, I mean that is the diastolic knock, right? It's the fluid overload one, whatever.
Yes.
And there's a 1/6 holosystolic murmur heard over the cardiac apex. She's got 3+ lower extremity edema up to her knees. So when you push down on her legs, she's doing something called pitting, which is, you leave your thumb imprint in your legs, and because there's so much fluid there, it actually ends up squishing down and leaving an imprint, and it's taking 3 seconds or more for that to basically puff back up. The remainder of the physical exam is within normal limits. All right, so yeah, I mean we're in fluid overload, definitely heading towards heart right now. But we'll see what all these other labs are saying. Sodium looks fine, potassium looks fine, chloride's fine, bicarb's fine, BUN's fine. Creatinine looks like she does have a little bit of an acute kidney injury. Calcium's fine, glucose looks fine. Total. Wait, is there no lab calculator on this one? Or does it just say, like, does it give you the normal value if something's abnormal?
Is it under resources, maybe?
I know for step 2 there's a lab value thing, or step 3.
Like the resources button. You see that on the bottom next to
true.
Yeah.
Okay. There we go. So, oh my god, I have to go through these. Okay, so albumin's low. T-Billy's fine. D-Billy is fine. Alk Phos looks a little low. Oh my god, this is terrible. Mild transaminitis. Biggest thing is the pro-BNP, which is quite high. So BNP stands for brain natriuretic peptide. For the context of heart failure, BNP is a chemical that's released. What is it? The stretching of the atria, right?
Yes.
So when you're in a fluid overloaded state and your heart is basically getting stretched because it's trying to accommodate for all that extra volume that it's got to push through, when your atria, which is the top chambers of the heart, end up stretching, they release something called BNP, and we kind of use that to correlate, somebody's heart failure status. The UI is not really user friendly, to put it nicely. Well, also I'm like super zoomed in, so it looks nice on the stream. So it is pretty terrible to use. Let's be real. All right, we got a nice EKG here. We got some depressions. Ooh.
Yeah.
But yeah, just major depressions, especially in lead 2. But it looks like regular rate and rhythm. I don't know. We'll do EKGs for another one that's like more cardiac. All right. So yeah, I mean, initial chest x-ray reveals cardiomegaly and bilateral pulmonary vascular congestion with small bilateral pleural effusions. So everybody's kind of been saying the same thing, right? Like, we are thinking about a heart failure picture, right? They've got a big sort of weak heart. It's cardiomegaly, which means that the heart size is big now because it's gotten all floppy and the pump isn't pumping forward correctly. We have bilateral pulmonary vascular congestion, meaning that these vessels are now getting engorged because the fluid isn't pumping forward, and small bilateral pleural effusions because now we're third spacing into the pleura of the lungs, and that's probably is what's causing, or that's just all of these is a consequence of the heart not pumping forward and the patient is having trouble breathing, which I think was her main complaint, right? Yeah, shortness of breath. So a transthoracic echocardiogram shows normal left ventricular size and a left ventricular ejection fraction of 65%. So an echocardiogram is an ultrasound of the heart. And this is something that you do in order to take a look at the structural abnormalities of the heart. You want to make sure that you get a good view of the valves, making sure that the sizes are good, that they're not too narrow, or they're not too, how would you describe regurgitation? Like floppy, or like back regurgitating?
Leaky, I guess.
Leaky, yeah, that's a good one. All right, not too narrow or not too leaky. And then a big thing, at least for medicine people, cardiologists probably care more about other things, but for us, like an ejection fraction is probably the simplest way to describe heart failure. So like a normal heart, you want to be pumping all of the blood that comes into the heart. You want to be pumping all of that out, right? So in this person, they're only pumping out about 65% of the blood that goes in and the blood that goes out. So they are backing up, and that's leading to a lot of their symptoms. Moderate concentric left ventricular hypertrophy is present. So they are having to do extra work on the left ventricle, which is the part that pumps through the aorta, which is the largest blood vessel in the body. And basically it's saying it's going to have to be overcoming a lot more just because the heart is so floppy. All right, the left atrium is moderately dilated, and we talked about this when we were talking about the BNP. A central jet of mild mitral regurgitation is present. So with mitral regurg, we were talking about the leakiness of the mitral valve, and that's basically saying that even when the atria is trying to empty into the ventricle, there's still a bit that's jetting back and remaining inside of the atria instead. Pulmonary artery systolic pressure is estimated at 45 millimeters of mercury, so there is some difficulty with getting blood into the pulmonary artery, which is the right side of the heart, where it's then going to go to the lungs, get oxygenated, and then go back to the left side of the heart so that it can get pumped out to the rest of the body. So a pulmonary artery pressure of 45 is quite elevated, so the right side is also having difficulty here, making sure everything goes through. So, all of that is to say, which of the following is the most appropriate next step in the management of this patient? So, we're thinking heart failure, right? What do we want to take a look at first? Optimal volume control, pulmonary function testing, right heart catheterization, treatment with angiotensin II receptive blockers, and treatment with beta blockers. Okay, let's see. So I think we're all saying that this is probably heart failure. And now it's a question of what kind of heart failure. We have a left ventricular ejection fraction of 65%. So, I mean, it's going to be heart failure with preserved ejection fraction. We also have proof that the right side is involved as well, because he does have an elevated right ventricular systolic pressure, or pulmonary artery systolic pressure, basically interchangeable there. So, I mean, in terms of diagnostics, the most appropriate next step, I mean, I'm already putting a name on this diagnosis, and we already have some of the numbers here to actually, make this diagnosis. So the next step that I want to manage this patient with is probably volume control. They are coming, to the hospital because they're short of breath and they have a lot of swelling on their body, right? I don't think I need to subject them to any more tests, in order to figure out what's going on here. The most important thing right now is that I try to get as much fluid off of their system as much as I can so that they can get off of this oxygen in the hospital and, hopefully, get started on a better diuretic regimen and, try to follow up with the heart doctor outside of the hospital. What do you think?
Yeah, this is a very technical question. There's like a lot of
going on here.
And big words. Yeah, there's a lot, and even the answers, I feel like there's a lot of detail here. So I think a lot of people in chat I was seeing had the sense that this is heart failure, right? It has that kind of picture. And for those who are unfamiliar with medicine, who may not been through med school yet or pre-med, what we call heart failure is really just telling the heart, you're not doing as good as you should, right? I actually had a patient who, when I said those words, they were like, I'm dying, my heart is failing? No way, no one told me that. And it doesn't mean that it's a imminently life-threatening problem, but it just means that your heart is not doing as good as it should, right? And it can get worse, and that's a problem, right? That's what heart failure is. Now, in this situation, this patient is coming to see Dr. Saiken in the hospital, right? In the hospital, not just out of the hospital in the clinic, because they're feeling sick. They're feeling out of breath. Things are not going good. They got swollen legs. Sometimes they can get so heavy you can barely walk because they're that swollen, or their shoes don't fit, their socks don't fit. And all those are things that patients notice and talk about. They're like, Doc, why are my feet so gigantic? What's happening? Right? And so to kind of get some explanation about what those all mean, right? If the heart's not doing so good, it's a pump. It's supposed to be pumping blood forward. You can think of it like the water pump in your house, right? If you're not pumping blood forward, water forward in your house, what happens? Your basement floods, or wherever your water pump is, it floods over because all the water can't get out. So then what's the body's equivalent of that? It's your legs and your lungs, because that's where the heart is taking the blood from and pushing it the other way out. So that's why people get water in their lungs, they get water in their legs, they get all that swelling and water in their lungs because of that, and that's why they feel sick, right? We call that decompensated heart failure, or like an acute heart failure exacerbation, which is just a fancy way of saying it's now worse. What do we do, right? So this patient's now coming to Dr. Saiken to say, how do I get this to feel better? Or should we do something to try to diagnose it, right? Which is what Saiken was getting at. And that's one of the tricks about questions like these is, do we need to do more to figure out what's happening, or do we know what's going on and we can skip all the other testing? That's where some of these question answers are confusing. You can see right there that most of these answers are actually fairly reasonable. B and E, I would say, are not reasonable for like very technical reasons, and that's why no one picked B and only like 1% of people picked E. But you can see C, 13% of people were like, maybe we should do this test. And it's a very like technical specific test that you can do to get more info to call it heart failure. But like Saiken was saying, if you already know it's heart failure, why make someone do this test? They're already feeling miserable. What we can do instead is to pull that water off, what we call volume control. Usually you have to get them pee all the water out. And that's what will make them feel better.
Yeah. So a lot of people in the YouTube chat, actually, especially, were, kind of debating what the correct answer is for here. So for me as a hospital medicine doctor, like heart failure exacerbations, like are my bread and butter, right? Like if I'm taking care of like 22 patients on my list, like I guarantee like at any given time, like at least 4 of them are going to be heart failure, right? It is a very common problem in America, a very common chronic disease that can get out of hand very quickly, especially in an older population. So for these things, yes, some people were right when they were saying beta blockers or the angiotensin receptor blockers. There are, pillars of heart failure medical treatment that we call GDMT, goal-directed medical therapy. And eventually, you want to get patients started on these 4 medicines. You want to get them started on an ACE inhibitor or an angiotensin 2 receptor blocker, or technically nowadays an ARNI, right, which is Entresto. But the ACE inhibitor, you would want to try something like lisinopril. The angiotensin receptor blocker, you'd want to try like irbesartan or whatever, the beta blocker, right? Something like metoprolol, to kind of slow the heart down, give it time to relax, give it time to fill up and pump out properly. You would also want to use a mineralocorticoid receptor antagonist, so something like spironolactone, also for that added diuretic effect. And you would also want to give them a SGLT2 inhibitor. Dapagliflozin is the big one now. I think that came out like our intern year of residency, right? Like that was like a pretty new recommendation from the DAPA-HF trial. Flozins, which are the SGLT2 inhibitors, are originally developed as diabetic medicines because they help you pee out sugar. But through a lot of landmarks, a lot of different trials and a landmark study, eventually like it became such a strong recommendation for patients with heart failure as well. Now it's part of our pillars. So talking about these things, you'll notice that diuretics actually wasn't part of that discussion at all. There is no improved mortality benefit from giving them diuretics from heart failure. But if I have a patient in the hospital that's extremely short of breath, very obviously fluid overloaded, and also requiring oxygen in the hospital, what I need to do to manage the patient, right? Not diagnose the patient, not, take care of the patient best for the next 20 years, but to manage this patient for the next 5 days, I need to make sure that their kidneys are able to take the brunt of all of this fluid overload and make them pee out as much water as I can. And doing that will actually get rid of their pleural effusions. That'll make their heart start doing less work. It'll reduce the amount of fluid that their heart has to pump out and pump against, and that'll get all of the fluid off of their lungs so that they can start breathing better and eventually be in a place where we can initiate these different medications on them. Somebody says diuretics would take too long. For a hospitalization, I would say, I think your average heart failure hospitalization probably takes about maybe 4 days, if we're calling this like respiratory failure from a heart failure exacerbation. So it takes about, 2 or 3 days of solid IV, medications like Lasix, Bumex, so furosemide or bumetanide, potentially even like nephron blockade, adding more diuretics on that in order to get the patient to pee out the water. But it's something, you're already in the hospital for, right? Like you are on oxygen. You didn't come here on oxygen. So my goal is to not discharge the patient on a new oxygen requirement. My goal is to make the patient back to their baseline so that they can follow up with their regular doctors outside of the hospital. Yeah, the heart failure is a very nuanced condition. I mean, yes, it seems easy enough to just say like, oh, just hit them with as much Lasix as possible and hope they pee it all out. But then you also have to weigh against. I think somebody was asking like, what happens if their kidneys can't handle it, right? What if you use so much Lasix that their potassium is dropping overnight, right? So there's a lot of different things going on here, and that's where you start having people like cardiology and nephrology fight each other. Like, oh, we gotta make sure the heart is healthy, and then the nephrologist says, but you can't do that at the expense of the kidneys. And then the pharmacist calls you at 3 a.m. and they're like, what the hell is going on here? Like, why are these specialists still fighting over what needs to be done? So hospital medicine is very fun. I like my job.
Have you seen this newest study, saiken, by the way, that maybe I should share with you later?
No, but
About
you totally should.
whether or not spironolactone is actually helpful in terms of mortality for HFpEF.
Oh, right.
Is,
Actually, yeah, no.
published, like,
For HFpEF,
yeah.
there are actually. Oh, wait. You still add the SGLT2 and HFpEF, right?
You do. That's right.
But it's like you don't do beta blockers or something. It's different from HFrEF, but I just don't remember
Yeah.
which part is
Yeah,
different.
beta blockers are not that helpful. Mineralocorticoid receptor antagonists were thought to be helpful, but there's there's a new mineralocorticoid receptor antagonist on the block called
Oh, wait.
finerenone, which is
Yeah.
and there was a new study. This is, by the way, for anyone who's not like a third-year resident, fellow, attending level, do not worry about this. This is like
This is
in
like
the weeds
new research.
entirely.
Yeah.
This was published. I think it was where was it published? It's called Spirit HF was the trial, but basically they tried to look at whether or not Spiro actually reduced mortality in HFpEF and mildly reduced CF. They saw that there was no difference, so that's why some cardiologists say you should only use finerenone for HFpEF. But it was apparently it was a controversial study, so who knows? But that was an interesting thing to look at.
For context, JF like works in an academic system, like a very fancy, famous academic system. And I work at like a decent like state academic system, but like in terms of like journal clubs, like constant new updates and all these sorts of things, like he is really on top of that. Like I have not gone to a single journal club since residency last year, so like he definitely like keeps on top of it a lot more than I do.
I'm like a small fish and like a like compared to some of my colleagues who this was like Monday morning. I was like half asleep, half awake. And this like old colleague of mine who's been a doctor for like 60 years hands me like a list of journals, like it's a newspaper. And he's like, hey, check this out, JF. Look at this paper right here. And I look at it, I'm like, that's cool. I'm not thinking this morning because it's Monday morning. So I might sound smart, but some of my colleagues, they blow me right out of the water with what they are experienced with. And I think that's what's cool about medicine sometimes. You got to just constantly adapt.
Somebody in the YouTube chat also said, McMahon7149 says, who makes the final call if two specialists disagree with the next course of action? Me. So this is also something I discussed in my internal medicine video. But as the hospitalist, right, like I am the primary doctor for the patient, right? So the patient belongs to me. My name is on the top of their chart, and any question that the patient has or the nurse has or the specialist has about their care goes directly to me first. So, I kind of call it like being the quarterback of the team, right? So I decide where I need to throw the ball to. Like if I'm dealing with a heart failure admission and the patient isn't getting better, I need to know like, okay, what is my threshold for getting cardiology involved to help me with this? Or what is my threshold for getting nephrology involved to help me with this? Sometimes it's extremely obvious. Like, if the patient needs a cath or like a procedure or a stent or dialysis, right? Like I can't put in dialysis orders. Like I need a nephrologist to do that, right? I don't know how to put in a stent into like the LAD. Like I need a cardiologist to do that. But, if I'm having cardiology and nephrology on the same case and they're giving conflicting opinions, opinions, it is up to me at the end of the day to make that decision. And that's usually because I'm the one that's sitting down with the patient, talking to them about the pros and cons, talking to the family about, hey, like these medications might be more expensive, or this way of thinking has a better, immediate benefit, but probably not as much in the next 10, 15 years. And making this kind of shared decision making that the level of the specialists aren't going to get into. But as the patient's primary doctor in the hospital, all of that comes down to me. And legally, that also comes back down to me too, right? So the specialists are there as consultants. They're just there to give their recommendations. Sometimes in some systems, the consultants don't even actually order anything, right? They just give you like a grocery list of things that we recommend, but they don't actually like put in those orders themselves. So everything eventually ends up coming down to the medicine doctor, to weigh those opinions, weigh the pros and cons, and talk about it with the patient, talk about it with the family, and see what is the best for that specific patient, right? You will have specialists that are a little more detached from the actual medical care, right? Like, oh, they're making $100 billion doing fancy procedures all day, but they don't understand, like, if this patient can't afford her medicines, there's no point trying to put her on the fanciest, newest, most evidence-based medicine. But if she can only afford what's on the Walmart $4 list, right, we're going to have to go down a path where we put her on medications that are only on the Walmart $4 list. And you think a cardiologist is going to know what that is? Probably not. So like that's where my job as the patient's primary doctor comes in, and where I offer my opinion and my training, interfacing with the nurses, interfacing with social work, and interfacing with like the pharmacy benefits manager and these sorts of things. So that's something that I really enjoy about my job. It gives me a lot of insight onto the medical system, and honestly, like American healthcare too. So yeah. Did I do this question? Is the next one yours? I think the next one's yours.
We took so long we forgot who did this question.
We've only done like 3 questions.
We're gonna fail this test, guys. This is great. Our time is not doing so.
Oh, is this a neuro one? Okay, yeah. Go ahead. You do.
Uh-oh. For context, when I was a medical student, I was supposed to learn neurology. It was the pandemic, so they canceled our neurology shelf exams.
You got canceled?
Yes.
Wow, that's
my
crazy.
medical school is like, nah, you guys are fine. You don't have to take this. And me at the time was like, okay, great, one less test for me. But now my neurology stinks. So
we had like super abbreviated rotations. Like so we're the same year. So our M3 year was 2020. We had like a 3-week neurology rotation, and we still had to take the shelf after that.
Oh gosh, I'm sorry.
So mine was like 1 week of epilepsy clinic, 1 week of pain management clinic, and 1 week of stroke floor. And of course, obviously, like stroke floor is going to be the most relevant. So I'm like 3 weeks into my neurology rotation, taking shelf the next day. I'm just like, oh my God, everything is only relevant from like the past 3 days.
The question in YouTube chat, what's usually the pace when solving these questions? Usually, what was it? It's like 60 questions for about like an hour and 15 minutes or 20 minutes or something like that was what it was supposed to be.
Out of sight, out of mind. I do not remember. Wait, actually, are you doing the longitudinal
saiken
like
one,
thingy,
saiken,
or
saiken
the
one, saiken.
every 5 years test?
I think I actually don't remember what I picked. I think that's something I should know, but I don't. Out of sight, out of mind, right?
Out of sight, out of
it's in
mind.
a few years. I don't care. I'll have to look into that. Thanks for reminding me. All right, let's get into this. By the way, for those who don't know, one of the ways we renew our doctor's licenses is we have to retake a giant test like this every few years. It didn't have to be this way. One of my attendings when I was a student, he was so old, he actually retired last year, and I'm taking all of his patients apparently because he loved me as a student so much that he was like, "Oh, see this doctor, he's great." But he's so old that back in his day, when he tested for his doctor's license, he could just take one test and be good for life. And that was it.
Dude, that is crazy to me. Like,
that's what I'm saying. I'm so jealous.
I'm not trying to
done.
shit on the old guard or anything, but like, dude, like, how are you still practicing in like 2026 or like the 2020s? Like when you went to med school and residency before like people even knew what mitochondria were. Like there should have been things like in place at that point. Oh my god.
You know what germ theory is? They're like, oh yes. They're just the miasma. That's what's causing your infection.
It's the humors.
Yes, bloodletting. I prescribe leeches. All right, let's get back into this question. So, a 72-year-old man comes to the emergency department after a brief episode of loss of consciousness. So they seemed like they passed out, but it was only for a short period of time, which is actually pretty important. The patient was waiting in line to purchase a movie ticket when he felt warmth and nausea and started sweating. Okay, details about what happened. He then collapsed to the ground and was unconscious for 1 to 2 minutes, so a pretty short period of time. According to his wife, who witnessed the episode, and that's always important, if someone witnessed the episode, ask them for what happened, because they can usually give you more details about what happened. If you imagine you passed out, you're not going to know what happened, but your partner or a passerby, a bystander, they can probably tell. He had 2 or 3 jerky movements of his arms. That's something to note too. No tongue biting or urinary incontinence. He didn't wet himself because of the fall or the loss of consciousness. The patient was briefly hospitalized after a similar episode about a year ago, and they got some tests. They got blood tests. They got an electrocardiogram, which looks at the rhythm of the heart, so the electricity like we saw earlier for the previous patient. And they did telemetry, which is where they hook you up to pads, little stickers, onto a heart monitor. And that's the thing that goes beeping in like the TV shows or the medical dramas and everything, right? Those are all normal at the time. So it's testing again. I guess whenever I have a question, things are normal. I don't know if it's just me, but patients seem to be doing okay then. Here's his past medical history that you ask. He's got high blood pressure. He's got high cholesterol. He's got type 2 diabetes, but it's diet controlled. So really, he doesn't need any medicine for it. He's doing pretty good. And he has something called diverticulosis, which is an outpouching of your bowels because of a few things. Like, for example, if you're constipated, your bowels, which are usually pretty malleable, can get punched out into like a hole, and that can cause problems. So from this, just from looking at the history, the things that stand out to me a lot is that it's a very short period of time, right? You think about people who pass out for one reason or another, right? If they're having something medically concerning that will be a reason to rush them to the hospital, a seizure, for example, that's something to think about, right? Those jerking movements, that could be a sign of a seizure, right? It could or it couldn't. You could also have had what we call syncope, which is what happens when the blood flow to the brain gets shut down for a quick second or two, right? You might feel this if you have a fear of blood and someone pokes you to get a blood draw and you pass out, right? Some people say, I can't stand blood draws because I pass out when that happens. Other times it could be because of a heart problem, right? Your heart's beating wrong and then it's not pumping blood forward. Kind of like the last person we saw, right? Could be another thing. Or maybe they had a stroke or something with their brain that turned the blood off, right? So there's a lot of high value real estate in some of these areas. Something definitely take seriously. I use that phrase for patients. I say that all the time, and I think patients like it, but I don't know. That's when they say like chest pain, I'm like, that's a high value real estate. You got your heart and your lungs in there. Pretty important.
I mean, it's true. It's true.
It is true. It is true.
So what's low value real estate? Like they have like middle finger pain or something?
Yeah, I saw one of those people today.
Or my anterior thigh really burns, doc. And you're like low value.
Sciatica. Low value real estate.
I wouldn't put too much in there.
Doc, my scalp is itchy. Oh, that's low value real estate. That's okay. Just use some shampoo. You're fine.
Oh, we got a Twitch raid from Bon. Zala, hello, mahjongers. What's up, everybody? My name is Saiken, MD. I am a Dr. VTuber, internal medicine doctor in real life. Today, we are doing internal medicine board review with my fellow internal medicine doctor, JFMD. We both graduated residency last year, and now a year out, in real world medicine, we are going back to the exam prep and seeing if we can actually, answer these. But we're like 4 for 4 so far, so we're doing better than I thought we would. These questions are also quite easy. I don't think there have been any of the ones yet where it's like 10% of the people got it correct.
You're going to jinx it. You're going to jinx this.
Oh my god. It is a neuro question. I don't know.
Yeah, or is it? Is it a neuro question? All right, so kind of briefly went over the differential there, right? It could definitely be something neuro-related, brain or nerve-related, or it could be something heart, or it could be something not any of those kind of, right? It could be an episode of syncope from something else that we can go into. So when we think about those differential diagnoses, right, we got to think about what are we looking for on exam that could point us there, right? That's always kind of what doctors try to do after we ask you a ton of questions. It's not just because we want to know if you have a dog or not, because we're trying to figure out what could shape what our suspicions are, right? They try to show it on the TV shows. I don't know if they do a great job because they know the answer. We don't know the answer, right? Not necessarily, although I guess we might know the answer to this one. So we take a look, for example, at their vital signs. Is their blood pressure down? Is that why they're passing out? Because they're not getting blood flow to their brain because their blood pressure is nothing. Turns out his blood pressure is pretty good, right? Heart rate. Is their heart going really fast and not beating super well? No, it's doing pretty good here. And then orthostatic changes. That's a pretty interesting term, but what it means is, does your blood pressure drop if we try to move your position from like a lying down position to a sitting position or a sitting to a standing, right? And the reason why that's important is because if you're dehydrated or if you got something wrong with your autonomic nervous system that's controlling that, then your blood pressure could tank when you try to sit or stand up, right? I know someone who has that happen to them. And if that happens, you can pass out because the blood's not going up to your brain like it should. In this case, this person's also doing fine. In fact, they tell you, the person's alert and interactive. They're talking to you. I know some of my patients sometimes in clinic, they're not really that interactive. I don't know if it's my fault or if it's because that's just their concerns. But this person is talking, is answering questions, seems to be participating with you. Sounds like a person who's doing pretty okay right now, right?
Yeah,
Can you take
so
a listen to their heart?
a lot of people in the YouTube chat are really split on this too, right? I mean, it's D, it's E, it's B, it's C. I think everybody's at least said something except A. I don't think anyone said A so far yet. Mm-hmm. But yeah, I mean, I agree. There's a lot of benign sounding stuff going on.
Yeah.
Somebody says, how fast does the tilt table go? Enough to make you miserable. I mean, I think tilt table testing was a very common way outpatient like years ago for diagnosing these sorts of dysautonomia issues. But like, I think nowadays people are more shying away from it just because of how like violent and like miserable it is for the actual patient getting the test done. And like diagnostic value wise, you would probably try to do things like orthostats first before you would subject them to a tilt table test.
Actually, there's a non-tilt table test that we can do without any equipment. It's called the NASA lean test. I literally learned about this last week when one of my colleagues in the primary care clinic told me when I was like, how do I do a tilt table test? You literally can just have someone lean against a wall. And if you do it the right way, it can be just as helpful as a tilt table test.
The
so
NASA
there you go.
10-minute lean test?
Yeah.
Wow, it really is just they're really just leaning.
Yeah.
Oh, wow. Okay. Cool.
Who needs tilt table testing anymore? Someone tell Brie.
As somebody who had a tilt table test, it was borderline torture in my opinion. Yeah, that's what I've heard. All right. Yeah. So, I mean, yeah, a lot of people seem like they're pretty split. I mean, this guy clearly seems like there's something wrong, right? Potentially he collapsed, had some jerking movements. You know, are you worried about a seizure? Are you worried about him passing out? Are you worried about his heart? I don't know. Do you want to go through your logic and then I'll go through my logic, or do you want my logic and then your logic?
I can go first.
Okay.
So I think, long story short, I think that I'm going to actually go ahead and pick B.
Okay, yeah. My pointer was on B also.
So, and the reason why I'm picking B is for a few reasons, right? So, what do I think this diagnosis is? Just by kind of after my long-winded explanations of things, I think it's something called vasovagal syncope. Syncope is, like we said earlier, issues with blood flow to the brain, and sometimes that can happen in response to very intense emotional issues, stimulation, or events, right? Like we talked about drawing blood. And vasovagal syncope itself is fairly harmless. It's a sign of a reaction with the vagal nerve. That's where the name comes from, which is like a giant nerve inside of our body. And usually the recovery is swift, and there's no underlying signs of injury, like nerve injury, seizures, or anything like that, right? What are some clues that we have to this, right? They did all this testing before. The testing was fine. He already had an echocardiogram. He had blood tests. He had everything done. Those were normal. Blood pressure is fine. Orthostatics are also normal. That's another possible cause. And then you might say, what about the jerky motions? Isn't that a potential seizure? Well, the main things we think that are unlikely to be seizures, how short it was, right? You can have jerky motions with syncope that are not similar to like a generalized tonic-clonic seizure or even like a myoclonic seizure, right? And the fact that he recovered so quickly without any tongue biting, without any wetting himself, which are usually signs that the nerves are disinhibited, right? They're no longer being controlled because the brain's fried from a seizure. And he also didn't have any episodes of feeling confused afterwards, which is usually a sign we call a postictal state associated with a seizure. So because of that, we think less likely to be a serious problem. So fairly reassuring. So instead of doing all these tests that are going to be unnecessary, just send him home and have his primary care doctor see him, make sure he's doing okay.
Yeah. So I also think reassure and advise primary care provider follow up. I know sometimes like this answer doesn't always seem right? Like, 72-year-old man, like you think there is risk, right? Something could be wrong. You could be afraid that he might have had a seizure too. Even though things are less likely, you have to think about the benefit, right? Oftentimes, bringing someone to the hospital is not the correct answer, right? You're not magically going to have, an answer at the end of a hospitalization. And if you could have had the same result by just following up in the clinic, then did you really need to bring them to the hospital anyway? Hospitals are dangerous places, right? The amount of blood draws that you do, the lines, the nosocomial, the hospital-acquired infections. I mean, it is not a perfect place to put a 72-year-old man in. Hospital-acquired delirium is another one, right? So anytime you bring someone to the hospital, you have to weigh the pros and cons. If they have an acute issue that absolutely needs hospitalization, something that legitimately requires inpatient management, then yes, you need to bring them to the hospital. But if it's just for what is potentially a vasovagal syncope, something that can be worked up in the office and something that's immediately not causing any danger to them, you have to weigh the risks and benefits of actually bringing them in. So then you're also thinking about cost, you're thinking about use of resources, and you also want to, think about how much of the actual presentation here is reassuring. So the unconscious for 1 to 2 minutes, 2 to 3 jerkings of the arms, and no tongue biting or urinary incontinence makes me think this is less of a seizure. And if you notice, I highlighted this, when he read it, waiting in line to purchase a movie ticket. And he felt warmth and nausea too. Like this aura actually is what really kind of screams vasovagal for me. I think somebody said that maybe he was just locking his knees, right? If you were in like high school choir, or if you've ever been at like a music festival or a concert or something, right? The big thing they tell you is like, don't lock your knees, right? Make sure that you're constantly moving your legs, making sure the blood is circulating. Because, if you are in that prolonged standing position, your body at 72, might not adjust to that in time, and you can eventually pass out like that. There are a lot of things here that are reassuring, like a similar episode 1 year ago, which could have also been vasovagal. He already had the workup and the blood test, ECG, and telemetry, which is the long-term ECG monitoring. All of those things were normal too. So if you're able to connect those dots and realize that a repeat admission to discover the exact same negative results and would just be a waste of time for the patient, a waste of money for the patient, and a waste of resources for the patient that could be spent on somebody who's more sick instead, I'm going to agree, and I'm going to say B here. Yay! Yeah, so this was a tough one. Yeah. I mean, 37% got it right, which means 60 yeah, 63% of people got it wrong. And a lot of people also said, tilt table testing, right? Because, what if it is, something that could be in the autonomic nervous system? So it's not unclear in this case if this guy doesn't have a history, or that we're still working up neurocardiogenic syncope. And especially with the fact that he didn't have orthostatic changes, meaning that from lying down to sitting to standing, his blood pressure and his heart rate did not change significantly. But yeah, I think the age can be a bit enticing. I think, medico-legally, especially in America where everyone's so gung-ho to sue and stuff, like there are probably times where a hospitalist might be pressured to like admit to observation or something, and because the patient is pushing or the family is pushing, to say, okay, we'll monitor you and we'll just make sure, right? From a test question standpoint, that is definitely the wrong answer for all the reasons that I just said. But like for the actual practice of it, yeah, I could probably see myself admitting this guy, if somebody really pushed for it. Do you agree with that?
Yeah.
Like if you were a PCP and you were calling in like, hey, I need this guy admitted, like would you push
Yeah, I
somebody?
mean,
Yeah, like he's
I don't know if I would
72,
argue
he's old,
back.
you don't know, right?
Yeah, but to tell you the truth, having worked in my ER as well, I would guarantee that our ER would admit this patient to you, to the
Oh
hospital
yeah,
service.
they also would have already done a CT head too.
Oh yeah, 100%.
No, they would have done a full body CT also. At my hospital, this guy's getting a neuro consult, admitted for obs and a CT scan and repeat blood work.
Code
Yeah,
stroke.
Yeah, exactly. He probably came in as a code stroke too.
Oh yeah, I'm sure.
Blazing Shinx says, hey everyone, I'm new here and I'm actually getting into med school starting September. Congrats! Does anyone have
Congrats.
any advice how to pass anatomy and specifically the practicals part of the course? So I was a gross anatomy TA in med school actually. So I taught the anatomy lab section for the M1s, and I also did pro sections with the oh my god, I almost called him the attending, the professor who was a retired general surgeon. But for the practicals especially, to be honest, the best way to study is to just look at as many bodies as possible. Like you should be trying to look at all of the tanks in your room, or however many tanks that your school has. You want to see if you can go through as many of the different bodies as possible, just because with things like anatomic variation between male and female cadavers, younger and older cadavers, skinnier or fatter cadavers, like things will look different, and being able to recognize it on different bodies is probably the best way to get yourself familiar with like the anatomy and the anatomical landmarks. More specifically to my my class at my school, like we did our anatomy practicals on everybody else's cadavers, right? So we set up the individual labs with like the different pins and the flags on the students' actual cadavers. So if you studied everybody's cadavers and you knew where to find X, Y, or Z structure on everybody's cadavers, then there were only so many ways that the TAs could tag the different structures on the practical. So if you don't do like, virtual practicals with like images, it's really just getting time in the lab and just looking at as many bodies as you can. Was your school the same like that too?
Yeah, it was especially even before the test, where if someone were to find something interesting in their cadaver, the professor would literally say, everyone gather around, take a look at this. What do you think this is? Or things like that. There really was encouragement to like look at different variations, because everybody's body is different, even when we are studying for a medical student test.
Oh yeah, I remember there's just like they would tag some bullshit, like the correct answer was the pericardiocophrenic vein or whatever. And it's like this is completely irrelevant to anything, but like, oh, you remember 2 weeks ago the TA called everyone over because they're like, guys, look, this is an amazing pericardiocophrenic vein. And then on the test, you'd see the pin there, yeah, and then you'd be like, oh, I know exactly what this is. Just a pile of people looking. I mean, honestly, yeah. I think it's unfortunate that I'm gonna sound like such a boomer right now, but like post-COVID, a lot of med schools had trouble getting cadavers, and processing cadavers for their cadaver labs. And I think a lot of I guess not at my med school, and I imagine not at your med school, JF, but a lot of smaller med schools, weren't able to provide cadavers for their students, and they moved on to like virtual dissectors, and like using like computer programs like Netters or whatever like the 3D modeling thing is. And it's disappointing, right? I mean, like I remember like the first day of anatomy, like opening up like the tank and like seeing your body for the first time, and you're just like one, damn, I'm here like in med school, like dissecting a body. Like I barely know how to use these tools and everything, but it's just like a learning experience that you're not going to replicate anywhere else, right? Like actually like reflecting muscles, like cutting things and like teasing out nerves. Like there is like skills and that like physical association almost between like all of the machinery of the human body that I just think you're not going to get from just like looking at Netters, like the atlas and all that stuff.
Right, exactly.
All right. I'll do the next one. 65-year-old man comes to the emergency department because of worsening generalized itching for 7 days. He has experienced abdominal discomfort, bloating, and decreased appetite for several weeks. He's lost about 10 to 12 pounds during this time, which he attributes to excessive stress at work, or, probably because he's not eating enough. He denies nausea, vomiting, diarrhea, easy bleeding, or bruising. All right. So, I mean, I'm thinking, gallbladder, some biliary symptoms, pruritic rashes. He's not, eating as much, which is leading to him having these weight losses, but it's not like a lower GI symptom where he's just actively pooping out so much stool or free water that he's having these metabolic changes. So yeah, 10 to 12 pounds in 7 days. Like that's pretty bad, right? So his temperature is 98.4, so not really looking like an infection. Blood pressure is 123/70, and pulse is 78 per minute and regular. So his body is compensating, and he's, doing pretty well medically. He is clinically stable. On examination, he has icteric conjunctivae and skin. All right, so he's jaundiced. He's got yellowing of the eyes and his skin, and he's got bilateral diffuse stretch marks, and there's mild tenderness on palpation of his right upper abdominal quadrant. So we're looking at his liver here, and that is slightly tender, or the gallbladder, and it's slightly tender. Tip of the spleen is not palpable, meaning that he doesn't have any splenomegaly. All right. So we're looking at his blood count. CBC looks fine. Platelets look fine. Leukocytes, it looks fine. He does have some lymphocytosis going on. White blood cells are normal. Liver function studies is dude. How come I never memorize Albus 3.5? Okay, so his albumin's fine. His bili, T-bili, and D-bili are definitely elevated here. Alk Phos is also elevated. And do we have a GGT? We don't, but I'm pretty sure it's coming from the gallbladder here. And he's got transaminitis as well. All right. So definitely pointing towards a like gallbladder, liver, pancreas, that sort of area on the GI tract. Abdominal ultrasound reveals an enlarged liver with dilated intrahepatic bile ducts. Okay, so we've got some backup going on. CT scan of the abdomen reveals an ill-defined 3.5 centimeter pancreatic mass. Oh no. And several low attenuating foci in the liver consistent with metastases. Okay, so this pretty much spiraled to pancreatic cancer pretty quickly. Oh, wow. So which of the following is the best next step in managing this patient? Yeah, so immediately going for the cancer diagnosis. Yeah, they just threw cancer at you. Actually, no, but this is a good thing, following up on the thing that I just said, right? So he has a pancreatic mass and he's got mets to the liver, right? So when you're thinking about anatomical relationships, he also has dilated intrahepatic bile ducts, which means that his metastases, or the actual mass itself, is pushing on this functional tissue in the liver and obstructing his bile ducts, leading to that kind of bile lake pathology that I was talking about up here, leading to his jaundice and everything. So he does have pruritic rashing. He does have extreme weight loss from this pancreatic cancer. But actually, in order to get this guy feeling better, I need to make sure that those bile ducts are actually draining and making sure that he's actually able to relieve this obstruction and actually able to start, eating food again without feeling like crap. Like, yes, he has pancreatic cancer and there is a lot going on here. But if I was, yeah, this man is in the emergency department. If I was the hospitalist admitting him, like, that is the first thing I am calling the GI doctor for. Like, I'm not trying to give, well, actually, do I want to give him pain meds too? Like, he's not in pain, right? He's just itching. Okay, right.
Yeah,
so,
he's itching.
So yeah, he's pruritic, itching, and he's jaundiced, right? So I want to make sure I can alleviate his symptoms first, and then we can get on board the oncologists, the surgeons, give him, ursodiol, whatever he needs, potentially chemo. So yeah. Do you agree with me?
Yeah, I agree. I think the question writers are trying to catch you maybe with between A and C, right? Because you could do a biliary decompression surgery to relieve the pressure on his biliary ducts, or you could do a stent. Which one is better?
Actually, well, I mean, and I've never actually had a patient undergo biliary decompression. Like, they've actually, like, GI has always like put in one of those like stents, like bare metal stents or whatever.
Yeah.
Actually, what does biliary decompression actually entail here? Because
Is it like debulking or something?
right, but like he doesn't really need debulking because it's the tumor burden that's like compressing it from the outside, right? So
Right.
it's not like it would help. Like, you need to put in a stent so that the actual bile duct gets. He's overthinking, right? Yeah, he's fuck it. Okay, good.
There we go.
Damn, you got me there. All right, yeah, here we go. Surgical biliary decompression, like a cholecystojejunostomy. Okay, so connecting the gallbladder to the jejunum or the choledocho. So connecting the CBD to the jejunum is reserved for patients who cannot go under. Yeah. Okay. So you would do the decompression by like creating a connection to allow the biliary system to drain directly into the small intestine instead of stenting the existing roads, basically. And you would only do that if they can't undergo stenting because of however the anatomy is presenting itself. But yeah, so pancreatic cancer, scary disease, 7 days, right? Like, all of this really came on in the past 7 days. He started losing a lot of weight in the past 7 days. Like, you'll start to see this constellation of symptoms quite often, and it'll creep up on them, and suddenly it'll get them to the point where they go into the ER. And this presentation is definitely not uncommon. Like, probably weight loss. Honestly, like, anytime I see weight loss in a question stem, you always think pancreatic cancer kind of in the back of your mind, because that's usually what the patient's coming in complaining of. But in terms of management, yeah, stenting. So a stent is basically like a hollow tube, kind of, and the biliary tree is just these biliary ducts that live inside the liver and are part of the biliary system. And if you have a tumor that's pushing on one of the ducts and it's causing it to back up because of the obstruction, you place a stent in and it kind of balloons it outward and you allow the actual tube to drain. So yeah, cool. Why pancreatic cancer in particular? I mean, I think just this non-scientific reasoning, but it's just the aggressiveness of pancreatic cancer. Like, this guy already has metastases as well. The obvious like metabolic burden of an active cancer, and the fact that it has GI symptoms too, where the patients aren't eating as much because they feel full really quickly, and that also leads to a significant amount of weight loss. What is endoscopic stenting doing here? It's the right answer. Can you tell at what stage of cancer the patient has with these symptoms? Oh, do you want to talk about grading and staging while I go pee?
Yeah, sure. Go
Cool.
for it. I'll hold down the fort. So, so I'll do like a brief explanation of grading and staging first, and then I'll answer your question. So the two things that cancer doctors care about the most are how far is something spread, and then how advanced is the cancer? Like, how different is it from what it's normally supposed to be, right? And so the first thing describes staging, which is how far away it's managed to go. If it's metastatic, if it's in the local area, is it in a lymph node, or is it just where it is and nowhere else? And then Grading is what we say how different it is pathologically. So if you biopsy it, take a piece of it, look at it under the microscope, how ugly does it look, for lack of a better word, compared to what's normal, healthy tissue, right? And so to answer your question, can we tell what the stage is based on symptoms, in particular these symptoms? And the answer is usually not, but in particular cases, actually we can, right? Because if something has spread beyond where it's supposed to be to a different organ system, then we can tell it's stage 4. It's metastatic to somewhere else. We don't need to do a full body scan to figure out, yeah, you've got something where it's not supposed to be far enough away that we think it's likely stage 4. We'd still probably do the scans in practice because we need to figure out where it is so we can target it with whether it's radiation therapy, surgery, or any other more targeted forms of therapy besides, in general, just systemic chemotherapy. But you can have a good clue even before we meet them in the scanner based on their history and what they're talking about. Grading, we usually have to do a biopsy, of course, because unfortunately our eyes can't zoom in close enough to see the cells. So we'll have to take a piece out or have a surgeon cut a piece out in order to actually take a look under the microscope. And that's where our wonderful pathology colleagues do their work, staining it and pressing it, freezing it, all those things. So we can really look at the cells in the microscope to see what they look like.
I like how I can just we can just like talk about this off the top of our heads. Like I could just be like, hey, I gotta go pee. Take over for me.
Take over.
But I
got
mean, like
you.
that's like why I enjoy doing this kind of content, like on stream or just like in general, right? Because like, and especially you understand this from like a primary care perspective. Like there's so many questions that you can ask your doctor. And, you know, of course, when you say like, oh, do you have any questions for me? Like the patients never say anything, right? But there's just like a lot of knowledge out there that not necessarily is like medical school level knowledge, but I think like extremely relevant for a lot of people either dealing with, you know, their own issues, issues of a family member, just to like understand what's going on. And I think just more people can benefit just from being aware, right? Not even just educated on the details and, you know, why we do certain things or like how these things work, but, you know, just understanding like what the process is like, and at least having a window into the baseline conversation that goes in to, you know, understanding a diagnosis, right? And probably not stuff you're able to fit into like a 25 minute patient encounter.
Yeah, exactly. But it's always appreciated whenever we as doctors have time to give it even a little bit of information about the details, how things work, or how we think about things. I've always done my best to. That's why I always run late. In fact, Saiken was like, when are you out of clinic today? And I'm like, I don't know, because probably going to run late today, because I always try to explain things. But it's something that we don't always do, whether it's in the hospital or in the clinic, just because it takes up a lot of our precious time, unfortunately. And if we run behind, then the patient after the one you're talking to is going to run late, and that's not a good thing. But at the same time, we do want to do a better job of explaining. That's absolutely something that I know Saiken's talked a lot about, that I 100% agree with.
Yeah, I'm a little sheltered because like as a hospitalist, right? Like all of my patients are already there, right? And I try to see everybody within like a 3-hour window, and then I go talk to my case managers and stuff. But like I have the privilege of, you know, being able to follow up, you know, later, like at 3 o'clock or 4 o'clock, and sit down with the family and talk to them about these things. Like not all doctors are going to be able to have that conversation. And usually because they're in the hospital, the patients and the families are a lot more receptive and curious to what you have to say. So, you know, at least my patient population, I have the time during the day to actually do these things and have these conversations with them, which, you know, JF and I are trying to translate onto the internet, you know, as VTubers too.
Yeah, definitely.
Cool. All right.
Ready. My
Take
turn.
it away.
So a 46-year-old woman is seen in the emergency department for severe headache, accompanied by nausea since she awoke this morning. She was diagnosed with hypertension or high blood pressure 7 years ago and took medicines for only 2 years. And then the patient stopped the medicines and did not follow up with doctors because she felt fine. It's actually something that I see a lot. She has a history of remote but not active intravenous drug use, and she's a current smoker with a 20-pack year history. So both important details about what her habits are. Again, kind of similar to what Saiken's talked about before, we don't judge, or rather we're not supposed to judge. I know doctors unfortunately do, because we're human. But the goal of asking these questions is not to say, haha, you do drugs, it's bad, you're a bad person, but to kind of get a sense of how can this factor into your health, especially if you come to the emergency room feeling awful, right? Feeling a severe headache, feeling really nauseous. So just by looking at this, things I'm thinking about, right? She's relatively young. She has some history of high blood pressure and is not taking any medication. So I'm thinking, is she having really, really high blood pressure, what we call hypertensive emergency, which can sometimes happen? And, or is it something else? Is it related to her history of remote drug use that could have turned into something that was brewing for many years? Let's go take a look at what the vital signs and everything show. So they do her vital signs pretty quick. She has a slightly elevated temperature, though not technically a real fever. The cutoff we usually say in Fahrenheit is 100.4 or 38 degrees Celsius. So not really a real fever, but a little high. Blood pressure, as I was maybe thinking about earlier, is quite high, 176/105, which is pretty high.
But it's not exactly hypertensive emergency, though.
Exactly.
Technically,
yeah, it's high.
180 is where you're worried about.
Mm-hmm.
But definitely
And the heart
enough
rate,
that something's wrong.
yeah, 100%. Especially when accompanied by how she's feeling, right? In the clinical context of things, something is up. And these blood pressure numbers don't look really reassuring for it, right? Pulse is a little high, 100's like borderline as well. So definitely some concerning numbers here. She appears lethargic. She feels less reactive when you talk to her, maybe a little bit sleepy, maybe a little bit not entirely with you when you talk to her. Mild neck stiffness, that's usually a concerning sign. Yeah. And then you take a listen to her heart, you hear a murmur, apical 2 out of 6 holosystolic murmur, which is a way to describe kind of a murmur that happens when the heart squeezes, and it's loudest at the very bottom, which is very confusingly the apex of the heart, just because that's how people decide to name things. Lungs sound clear, which will be important later when we talk about hypertensive emergency. Deep abdominal palpation shows bilateral firm flank masses. So that's not supposed to be there. Why are there masses inside? Yeah.
Actually, I'm gonna make that one a different color because this changes this changes the
everything.
Game.
There is no peripheral edema or skin rash, and there's no focal muscle weakness or cranial nerve deficit. So really nothing else on the skin, nothing else on the nerves. We get an electrocardiogram ECG shows sinus tachycardia, left ventricular hypertrophy. So the left ventricle is bigger than it's supposed to be, which can be signs of like chronic high blood pressure that's not very well controlled. And then you also see some secondary ST segment and T wave changes, which is a little bit technical, but in this situation, I think the context shows it's probably also related to chronic high blood pressure changes and maybe even a sign that her heart can't keep up if her blood pressure is too high, what we call demand ischemia. All right, blood tests. We get some blood tests here. All right, let's see. Hematocrit 40%, platelets 140,000, leukocytes 6,100. All right, those look pretty normal, but the serum chemistry, creatinine's high at 2.2. Now, we don't know her baseline, but she said, or at least what we can tell, no past history of any kidney problems. So we can assume this is very different and abnormal from what it's supposed to be, right? For analysis, we get a urine test, and it looks like there's some protein there and definitely abnormal white and red blood cells, and a lot of red blood cells too. Something that definitely is leaking through the kidneys or something is damaged about the kidneys, which makes sense with the creatinine, which is a test that we look at to look for kidney function as a marker of kidney filtration.
Yeah, so even, I mean, honestly, even before we go to the answer choices, like, I know we were saying, like, you know, everything in the question stem is important. Every positive finding is important. You know, every negative finding is important. But the one that I highlighted in a different color, bilateral firm flank masses. So this is definitely pointing towards like a physical kidney issue. And, you know, this is just an abnormal finding, period, right? Like, you should not feel masses on the patient's flank at all. So, I mean, before we're even interpreting any of these labs in this context, like, I'm already not really worried about like individual, like an acute kidney injury or like a specific, you know, kidney pathology like glomerulonephritis or like a nephrotic injury. Like, I'm kind of worried, like, what are these masses doing here? And I feel like, you know, you're right, we have like 60 questions in an hour and a half or something like that, right? Like, if you don't read it carefully, and you just scroll past this, like, and you don't recognize that, oh, whoa, they had bilateral firm flank masses on the physical exam. Like, I've definitely done that before on the tests, or like on UWorld. Oh, sorry, or on the board prep too. So like, definitely, like, you sometimes miss like very important information that changes the entire trajectory of the case. All right,
Exactly.
diagnose the headache.
Mm-hmm. All right. So I think, and this is what I'm putting down here. I think the headache, the high blood pressure, I think a few things are definitely related here from those bilateral masses, right? And if you think about what could be going on that can kind of come and go, really related to high blood pressure and someone who's really quite young, that's the other thing, right? Is that this person otherwise is quite young, and we don't really expect them to have really high blood pressure for not much reason, right?
She
Usually, I think
was
that's more of an older
diagnosed with
person
it at
disease.
39, which
Yeah,
still is pretty early. And then she
yeah,
was probably uncontrolled from 41 to 46.
yeah. So I think, when I think about those masses, I think about uncontrolled high blood pressure in someone who's that young, and potentially coming and going. I'm starting to think of whether or not this is something related to either like cysts in the kidneys, polycystic kidney disease, or is it related to adrenals or not? Now, this is bilateral, which is a little bit atypical for like a particular mass from the adrenals, although it could be adrenal hyperplasia. That could be it, though I think less likely. Um, so if we do test taking techniques here, brain metastasis probably not likely. I think it's cancer. Hypertensive encephalopathy, it could be that, though the blood pressure, like Saiken mentioned, is not what we consider to be in the range of hypertensive emergency, which is 180, usually systolic, the top number. But I think it's possible, but less likely. Non-communicating hydrocephalus, I think, is probably less likely related to our normal neurologic findings. Subarachnoid hemorrhage, if we think it's polycystic kidney disease, PKD, then it could be that. And then viral encephalitis, we think is less likely given the normal white count, although, and lack of fever, though it might hidden away if we don't do a lumbar puncture. But I think it's less likely that too. So really, I'm thinking either B or D here. I think if we have to choose one, I'd probably lean more towards D than B, but I think this can definitely be tricky.
I think, yeah, I'm also leaning more towards D, but, for an acute presentation, B could also be there, right? My concern is that she has had blood pressure problems for the past 7 years and has been uncontrolled for the past 5 years, and she's still smoking, right? And she's coming in hypertensive and lethargic. So even though, like, yeah, this could be an isolated episode of hypertensive encephalopathy, there are too many red flags in the history pointing at why she could be having a new stroke. And I think with, the firm flank masses being, polycystic kidney disease, I mean, that's going to be a very difficult, like, blood pressure to control in your adult life. And the more time you spend at living in the 170s, 180s, your risk for stroke is just going to increase and increase from there. A lot of people, a lot of people are saying leaning on B, right? Like, I don't think B is entirely wrong, right? Like, maybe you have 10 patients that present like this in the ER. Like, not all of them might have, like, 10 patients with polycystic kidney disease, let's say that, right? Like, not all of them might be actively stroking out. Like, they could be having hypertensive encephalopathy, but I think the most likely one is that she's having a new stroke here.
Yeah, I think the other thing to think about too is when you think about the headache, this is like a med student flashcard thing, right? It's like a buzzword, what we call a thunderclap headache. Like, it's really intense all at once. It's almost certainly because of a subarachnoid hemorrhage. Now, they don't say the words thunderclap on here, right? But they say really severe headache since she woke up this morning. Now, I guess we don't know what time of the day it is, but if she got rushed to the ER immediately after she felt this headache, it just started and it hit her hardest right away, then that would make me think D much more than B for sure. They don't give you the exact details though, so they try to make it confusing.
Yeah, I'm good with D.
Rounds to it.
Nice.
There we
Yeah,
go.
so 24% of people said hypertensive encephalopathy. So that was definitely on the differential for a lot of third-year resident internal medicine doctors too. So you guys definitely were not wrong like in that. But yeah, so polycystic kidney disease, like the bilateral flank firmness, like that probably was there too. So the cool thing about boards is that they will tell you, like in the study materials, why the answer was wrong. So although this patient may be at risk for hypertensive encephalopathy, her low-grade fever and neck stiffness indicate subarachnoid hemorrhage. Low-grade fever in general is common with intracranial hemorrhage. Her blood pressure is also not severe enough to cause hypertensive encephalopathy, which is greater than 180 over 120 millimeters of mercury. So yeah, like that one could be a technicality too, right? Like I wouldn't say like you need to have over 180, but I think for like the formal definition, they wouldn't give you like something outside of that, like on the exam. Boards is vague posting. Yeah. I mean, obviously, like if they wrote the word like patient describes they had a quote thunderclap headache, end quote, like that would be a little too obvious or something.
Yeah, it'd be a 100% correct question. They would be like, "Oh crap, you have to scrap this question for next year."
All right. Woo, okay. A lot of words, not a lot of laughs. 72-year-old man with a history of heart failure, reduced ejection fraction, comes to the office for follow-up. The patient reports no change in his chronic dyspnea on exertion, so shortness of breath with activity, but he says he's had a persistent, non-productive cough for the past 4 weeks. So the cough occurs during day and night, and he's not been able to get a restful sleep. The patient has had no fever, chills, night sweats, or loss of appetite. In the past year, he has had several hospitalizations due to decompensated heart failure. And then I had several admissions. And 6 months ago, he was treated with coronary stent for an episode of a non-ST elevation myocardial infarction. So he had a blocked blood vessel in his heart, and they went in, placed a stent, ballooned the artery open, and kept the blood flowing. Recent echocardiogram revealed an LVEF of 30%, so he does have, pretty significant disease. Patient's other medical problems include hypertension, hyperlipidemia, and osteoarthritis. He takes aspirin, ticagrelor, atorvastatin, furosemide, carvedilol, sacubitril, valsartan, and spironolactone. So like we were talking about for that goal-directed medical therapy right there, I mean, he's on the beta blocker, he's on the mineralocorticoid receptor antagonist, and he's on the ARNI, sacubitril, and he smoked half a pack of cigarettes daily for 10 years, but quit at age 40. The patient does not use alcohol or illicit drugs. Is it not ticagrelor? Brilinta! Brilinta! How do you say it?
I've always called it ticagrelor.
God damn.
Ticag.
Ticag?
Yeah, Ticag.
People say Ticag?
My cardiology attendings say Ticag.
Are they American?
Yeah.
Damn it. Dude, because it's like we had like an international like intern. I think she was from like Pakistan or something, but she always said like Clopey instead of clopidogrel. Well, like everybody says Plavix, but she was like, oh yeah, I'll add the Clopey on, and I'm like, oh, Clopey?
Oh, Clopey?
Ticag? All right. He takes aspirin, ticagrelor? Is that what he said?
Yeah.
He takes aspirin, Brilinta, Lipitor, Lasix, Coreg, and Tresto, and Aldactone. This stream is sponsored by Eli Lilly. All right, so he's on a lot of medicines. Big thing for me is the fact that he is on this, and this is a known thing that can cause cough. It's oh god, don't ask me. Bradykinin mediated cough reflex.
Yeah, you got it.
Yeah, okay. So that one's already a thing right there, right? So we're persistent non-productive cough. Like, are we thinking this is a medication side effect? Are we thinking this is uncontrolled heart failure? The difference between productive and non-productive, is he spitting up fluids? Is he spitting up phlegm? Or is this something that could be from one of the medications that he's on that has this as like a known side effect? So temperature is normal, blood pressure is a little low, but he is on a lot of antihypertensives. So for heart failure, I think that's okay. Pulse is regular, respirations are okay, and his pulse ox shows 96% on ambient air, so he's saturating fine. Weight is fine, unchanged from previous visits, so he's not super volume overloaded. One of the big things that we were tracking in the hospital, like we said with the previous heart failure question, is the amount of diuresis that you do, right? So a good question to ask is like, what's your normal weight? And then try to diurese the patient all the way back until they get to their normal weight, because otherwise the rest of the weight that they're on is just fluid. So his weight is unchanged, which means he's probably not holding on to that much free water. Physical exam shows normal nasal and oropharyngeal mucous membranes, so probably not like a respiratory tract infection. Poor dentition, okay. Normal jugular venous pressure, clear lungs, and a grade 2/6 systolic murmur at the left sternal border. Not really any red flags going on. Poor dentition could be due to a bunch of different reasons. Maybe, it's the classic one is like a 20 something year old woman who's like bulimic, so they're vomiting a lot, and they'll give poor dentition as like a giveaway for that. The abdomen is soft and non-tender, no hepatosplenomegaly, trace bilateral lower extremity pitting edema is present. So not 3+ like the other patient was, but trace. So I mean, all of this really is to say that his heart failure is actually pretty well controlled, right? He's not symptomatic, he's not requiring oxygen, right? He's not like super volume overloaded. Chest x-ray actually looks pretty good too. So which of the following is the most appropriate next step in the management of this patient? I mean, like I said, he's on a medication that is a very popular medication for heart failure, but the neprilysin inhibitor in the Entresto, the sacubitril, does have this as a known side effect. And I think the easiest thing right now is to discontinue sacubitril. Somebody says E, which I don't think is incorrect also, right? So poor dentition from chronic gastroesophageal reflux, right? He's making a lot of acid and that is refluxing. Prescribing a proton pump inhibitor to reduce that amount of acid probably makes sense in the context of this question. If they didn't say poor dentition, I don't think I would have considered E as an answer. But like the fact that they did kind of leads you astray, because I feel like that's not incorrect. But I think the next step, like the quickest thing to do first, would be to discontinue the sacubitril. I think you can probably talk more about this, like in an outpatient setting when somebody's coming in with chronic cough, like GERD is very high on your differential, right? Like you probably start a proton pump inhibitor anyway.
Yeah, 100%. Like things you have to think about too when doing that though is that PPIs or proton pump inhibitors are not entirely harmless, right? They change the pH of your stomach because they inhibit the acid production, right? And that can impact how medicines are absorbed. So I think primary care doctors historically have been very quick to just slap people on a PPI if they are having a cough or if they're having heartburn symptoms. It might not always be the best choice. And our gastroenterology colleagues have been constantly reminding us, stop the PPI or don't prescribe the PPI because people just set it and forget it, and it can be particularly problematic if that's the case. So I think in this case, it is a little bit, it can go both ways, right? The poor dentition could be, but you could say if they have normal mucous membranes, are they having acid reflux into those membranes that can cause inflammation or not? It's not a very like precise measure, but it can make things a little bit more uncertain, right? And then you want to really try to lean more on the patient's symptoms. Are they having nocturnal cough? Is it worse when they're lying down? That could suggest the acid's coming up and being irritating, or does it not matter if it's like daytime or nighttime, or if it's sitting or standing or lying down? Then it could be more so because of the sacubitril, right?
Yeah, actually,
so
that's a good point because it was during day and night too, right? Yeah. There you go. Cool.
Yeah, I'm just gonna that probably points more towards A.
Yeah, wow, 25% is a lot though, right?
Yeah.
Like that the fact that they said poor dentition, like even considering it as part of like vital information to give, that probably would have got me. But yeah, I mean, I think like easiest things being the simplest things, you'd rather, unless it's like a completely necessary like life-saving medication, like you'd probably discontinue the thing giving you a side effect before you try to add on something else to manage the side or manage another part of it. But yeah, so sacubitril, valsartan, aka Entresto, great medicine. A lot of cardiologists will eventually try to get their patients on this for heart failure, but it does tank their blood pressure. It does have this as a side effect. So if the patient can't tolerate it, then you want to go back to your ACEs or your ARBs instead. Or I guess not your ace. You would go for your ARB.
Maybe not the ace because of the
Yeah.
cough. Yeah.
Also, it's expensive. That's
Yes.
another one too. Like not all of your patients, like your Medicaid patient, is not going to be able to probably get on Entresto, but that's what you gotta talk to your social workers for, and somebody else who actually gets paid to learn the ins and outs of the American insurance system. Like I'll be honest,
Try telling
I
that to a
still,
cardiologist.
dude, I still don't know like the difference between like Part A, Part B, Part C, Part D.
Oh,
I
I had to learn
I think they
it.
do have like questions in here about that stuff, right?
Yes. Yeah, I'm pretty sure they do. It's probably more relevant in the outpatient setting because I do have to deal with Part B and D more so. Like the crash course is Part A is for inpatient hospital, so for you, okay, patients who see you. Part B is for
Okay.
clinic, so me,
Okay.
and then Part D is medicines, so like supplemental drug insurance, because Part A and B don't always cover all the medicines. So if someone doesn't have Part D, then they probably won't be able to get Entresto or like a lot of other useful medicines, unfortunately. Um, Versus if they had Part D, but you have to pay more money, right? You have to pay an additional fee every month, your premium to do that. So it gets very into the weeds. Social workers, they are miracle workers in trying to navigate that system, that plus private insurance and Medicaid and everything in between, which is
Mm,
why oftentimes we rely on them to help us with figuring out the ins and outs of insurance and what patients ultimately have to pay for.
yeah. I will say like I am a lot more sheltered from that. Like I try to involve myself with the case managers as much as I can just because it's just good to know, but I think like at the end of the day, like I mean, for you, how many case managers do you have in your clinic? Like two? One?
One
Yeah,
for all
exactly, right?
90 residents and like 30 attendings.
Jesus. Yeah, like in the hospital, like I have one per floor, right? So like I always have like somebody who's able to like get on this stuff and like they know like what to do and they'll take care of the problem. And I think a lot of I'm not gonna like stereotype a lot of hospitalists, but probably a lot of older hospitalists, as they are practicing more, they probably don't even interface with that system anymore just because they just do the medicine, right? But I think for me, like I'm still trying to learn, be a part of this cyberpunk dystopia healthcare system that we're a part of. So, like for me, I like sitting in on them, even outside of like interdisciplinary rounds and stuff. But like understanding, like, hey, like what is this form that I'm signing, right? Like, what is how does this thing work? Like, how does who pays for this or who pays for that? I mean, it is really interesting still.
Yeah,
All right.
and patients appreciate it when you consider it, right? When you don't just say, take this really expensive brand new medicine, but you're like, huh, I can tell based on either what you tell me, how your life is, your social history, or even just knowing what name your insurance has, that this might not be the best option for you. So let's try to do this instead, or find like a cheat code or like a shortcut in this crazy system that we have, like GoodRx or Mark Cuban's Cost Plus Pharmacy, things like that.
Mm-hmm.
Alrighty.
Ooh,
Next up, we got,
ID. Ooh.
yeah, ID. Diabetes, too, is something I see quite often. 63-year-old man with diabetes is hospitalized with right foot methicillin-resistant Staphylococcus aureus osteomyelitis. Big mouthful right there, but basically what it means is MRSA is the abbreviation that you may have heard of. It's a antibiotic-resistant bacteria that's unfortunately becoming really, really common, especially in the hospitals, but also in the communities too. And that infection is complicated by sepsis, which is like a body-wide inflammatory response due to a severe infection that can be life-threatening, and respiratory failure. So their breathing is failing because of this body-wide infection. He spends 3 days in the ICU on mechanical ventilation, which is the breathing machine, but is now extubated and has resumed eating. Perfect. So he's got the tube out and he's able to eat again. He has generalized weakness, mild cough, and foot pain, understandably, because his foot is infected. The patient has no chest pain, abdominal pain, bleeding, or diarrhea. He has no prior history of pneumonia, heart failure, or coagulopathy, which is all good things to not have. His current medications include IV vancomycin, which is an antibiotic we give for MRSA for this particular bacteria. Subcutaneous heparin, which is a blood thinner that we usually give to people as a protective measure to prevent blood clots from forming. Because when you're in the hospital, you can't move very well. One of the
Or
biggest
when
risk
you're,
factors
you're
for developing.
intubated. in
That
the
too.
ICU.
Yes. Yeah. In general, you can't move on in the hospital, but if you're stuck to a breathing machine and you're put to sleep, that too. Although he's now extubated, so he probably is out of that window for that. But still hospitalized, still with a foot infection, probably can't walk, or the doctors aren't letting him walk for a good reason. So he needs something to protect him from blood clots. Short and long-acting subcutaneous insulin and omeprazole. His vital signs are within normal limits. Okay, great. So it sounds like we got someone in the middle of a hospital admission. He's got a right foot infection. They give this to us straight up. They tell us his hospital course so far. He was in the weeds for a while, really ill in the ICU, but now he's better, which is great news. And they kind of just set us up for the next half of the question. What are they looking for? So they get blood tests as part of what we do routinely when we're giving patient medicines, and when they're in the hospital, especially, we check their blood count, we check their kidney function, and we check other blood tests as well. It looks like their creatinine is a little bit elevated, and the albumin is low, normally 3.5, and it's down by 1 full milligram per deciliter. And we check the coagulation profile for blood thinning because we're giving him a blood thinner, but that's normal, which is good. We're not overdoing things, so to speak. So which of the following should we be strongly considered when transferring this patient out of the ICU to the medical floor? So probably more of a question for someone at the resident level, right? This might not be something we tell students, especially because it's not related to what we typically think about as medicine, right? It's more like the practical stuff. How do hospitals work? When do we get patients out? It's like that dispo that you might have heard about from your attendings or your residents. Where do patients go, and how long will it take for them to get out of there, for example? When is it appropriate? When is it too early? When is it safe? Definitely something that saiken cares a lot about as both
Yeah.
a hospitalist and potentially an administrator in the future, right? This is exactly what he cares about.
This is why we
So let's
use the
see.
transfer order set, and you don't just move the patient.
Order reconciliation. You got to clean things up so things can move smoothly. All right. So what should we think about when patients are ready to get out of the ICU to the floor, which is the slang we use for the general hospital wards, like not the ICU, but where you typically go, for example, if you are hospitalized for something that's not life-threatening or acutely life-threatening. We stop proton pump inhibitor or the antacid. Should we give him some albumin because his albumin is low? Should we start oral diabetic medicines instead of the subcutaneous insulin? Should we switch his antibiotic from the IV to a pill? Or should we switch him off of the blood thinner, which is being injected into him under the skin, to like a mechanical massage device for his feet? What should we do? So I think this one's pretty straightforward, but it's a little hard to explain. So I don't know if you have a better way to explain to everyone about what goes into this thought process. Yes, it's A.
So it is. So this has to do with stress ulcers, right? Because if you're not eating, again, because you're in the ICU and you've been intubated and very critically ill, the common practice is to give every intubated patient a PPI. This reduces the amount of stomach acid that they're going to produce, and it'll protect against like gastrointestinal ulcer formation, which I think like the number is pretty high, like higher than you'd expect. Like I think like maybe 30% or something, but I mean it's enough to become like common practice. So basically somebody who's not using their digestive tract, someone who's not eating, still producing stomach acid, at risk of getting an ulcer. But now the patient is extubated and resumed eating, and they're not having any problems, right? They're not having any bleeding, diarrhea, they're not having like vomiting or whatever. So there really is no reason for the patient to be on a PPI anymore, right? It does mess up with absorption. It is not, it sounds like a good option for a lot of older patients just because, reflux is so common, but there are contraindications and there are, different problems and deficiencies that can result on just needlessly continuing a medication for no reason from the ICU. So yeah, definitely somebody who's already resumed eating and was only put on omeprazole in the ICU in a intubated setting does not need to be on omeprazole on the regular medical floor if they're already eating.
Perfect. That's a great explanation.
Yeah, I think somebody else also asked like pharmacologic to mechanical thromboprophylaxis. Yeah, so he's got like a big, osteomyelitis on his foot. I mean, he'll probably, if they haven't done it already, like they're probably going to have to take him to surgery too. So with a limb involved like that, doing the mechanical like squeezy socks or squeezing boots or whatever probably does not make sense there. Yeah.
Right.
I don't think. I mean, albumin infusion. He's already eating, right? So I'm not too concerned about nutritional deficiencies here. Now that he's going back to his regular diet, he'll be getting enough protein in his system. Starting oral diabetic medications. I mean, if he was like a severe diabetic in order to get to this point, like he's probably already on subcutaneous insulin and in the hospital as well. Yeah, so short and long acting subcutaneous insulin. So oral diabetic medication is not going to do anything for him that straight up giving him insulin won't. And then intravenous vanc to oral rifampin. Well, there hasn't been any conversation here yet about source control, right? He was just septic, just in the ICU. Really no reason to switch over or de-escalate the antibiotic therapy. I think he still needs to go to surgery or get whatever going on. Tifamin linked in the Twitch chat. I did a discussion on SEP during my ICU rotation. Here are the SCCM ASHP guidelines for anyone who wants to learn more about stress ulcer prophylaxis. Yeah, so I mean, definitely this is just a thing that, yeah, 89%. This is just a thing that you probably really only think of like in residency, right? Because when you're responsible for all the little minute details on like the transfer order and everything, like it's probably like the biggest thing that like red flags for you when you're trying to get somebody out of the ICU, begging the hospital lists to get them off of your ICU list so you can have one fewer patient to worry about.
Like the practical things that you don't necessarily think about when you're learning medicine before residency, but then when you're in the thick of it, actually having to put orders in and call people to transfer patients. Those are the details here that the test also looks for, because they expect you to have to learn this after 3 years of being a resident.
Yeah, and the nurse will be like, "Can you clean up the orders?" The hospitals will be like, "Can you make sure you use the transfer order set, clean up everything?" I think I said 30, you, right? 30 something percent. It's 15%, but yeah, it's pretty high, right? So incidence of bleeding in the ICU is approximately 1.5 to 8.5 patients in patients receiving ulcer prophylaxis versus 15% in those not receiving prophylaxis. So, yeah. Cool. All right. 82-year-old nursing home resident with a history of hypertension and COPD is brought to the emergency department after 2 days of fever, cough, and lethargy. So I think like they talk about this in like the first episode of The Pit or something. It's like 10 a.m. on the dot. Like you'll always have patients coming in from the nursing home because that's after like the nurses over there do their morning rounds, and then they find the patient in a bad way, and then they bring them over to the emergency department for admission. Like it'll always happen on the dot. You will have somebody admitted from a nursing home. But yeah, I mean those situations, like nursing homes are not perfect places, but they do their best. But patients can get very severely ill and can go to the hospital because of that. And the hospital will do their best and discharge them back to the nursing home. And that's why we have kind of a revolving door problem, especially in America. So yeah, I think in the episode too, they also say like the nurse is like super overworked. Like one nurse treats like 60, 70 patients in a nursing home setting, whereas like in the hospital, it's one nurse treating like 7 patients. So
yeah, we don't talk about this actually.
Very confusing time
for residents. Yeah, like for the distinction for like how much staff in each setting drops as you kind of de-escalate how acute the care is, right? So for example, in the last patient with the ICU, you have one nurse usually for 1 or 2 patients because you need that very close supervision for someone who's very ill. On the floor, you might have one RN, registered nurse, per 5 or 6 patients potentially, because there are more patients to take care of and you don't need as much close supervision, but it means that you can't always have that one-to-one. You need to do something right away. Please go to the patient acuity that you would have in the ICU. In the nursing home, it's even less, where you have potentially one RN on shift for the entire nursing home for 12 hours. And then in place of RNs seeing patients directly, you have CNAs or medical assistants being the ones who directly attend to the patients. And they may not be as knowledgeable as RNs just because that's not their specialty, right? That's not what they're trained for. They're trained to do like the turning of the patient or the feeding of the patient or, checking in on the patient, compared to RNs, which are more so medication administration, doing vital signs and doing more assessments, kind of more similar to what doctors do in the hospital. And patients don't always know that either, right? Sometimes patients have come to me and said, Why did I get sent to a nursing home? It was awful there. I only saw one doctor once a week and one nurse every day, instead of in the hospital where I saw a doctor every day and a nurse every like 4 hours. And part of it is expectations, and part of it is that we just don't do a great job of explaining what each of these settings are like. And also part of it is people being overworked and a lack of money funding for these places to actually get enough staff to take care of everybody there. It's a whole bunch of issues.
I feel like we're going down a rabbit hole, but I don't know. Did you do a geriatrics rotation like in your third year or something?
I did inpatient geriatrics my second year. I did outpatient geriatrics my first year. Yeah.
Yeah. So like I got to do outpatient geri my third year, and just the difference between like a 2-star nursing home and like a 5-star nursing home is staggering, right? Like not even thinking about staffing, but like conditions or everything. Like, yeah, insurance pays for it, but like insurance pays for it does not even cover like how classist the system can really be. You know, like
100%.
Those 5-star nursing homes, like the patient's gotta like mortgage their house, put down like a $200,000 down payment, but like those things are basically just like a resort light. Amazing staffing, like fountains and tennis courts and gardens and stuff. And then you just get to the ones that are subsidized by like Medicaid or something, and it is like a very poor expectation for families that are, you know, sending their loved ones for care there. But like for nursing homes, there's a lot that goes in on the social work end, where, you know, they send the patient, they describe the patient, they run it through their insurance, and basically they just see what facilities accept the patient or not. And, you know, if a facility accepts the patient and they're medically cleared, you know, sometimes I just have to discharge them there. They technically do not meet criteria to be in the hospital anymore. They have an open bed at a nursing facility that might not have great reviews, but, you know, they do need to go so that the hospital bed can go through somewhere else. So it is a very confusing system, and there are a lot of ramifications for it. But the reality is, like, this question, like, this probably happens to me like twice a day. Like, we get new patients all the time. I would say at least like 2 of these are sitting on my list too.
Yeah.
Ugh. All right, so he had fever, cough, lethargy. He was treated with acetaminophen at the nursing home, but was found to be very confused this morning. His oral intake has also been poor. His daily medications include lisinopril, hydrochlorothiazide, and tiotropium. He has never been hospitalized for a COPD exacerbation or pneumonia. At the nursing home, there have been 2 cases of mild febrile illness over the past 2 weeks. All right. So I think somebody in the YouTube chat said this too. Like, is this like a nursing home acquired infection? I mean, yeah, like going off the thing that I just said, like sometimes these facilities really do not have the staffing or their money to keep these places great. And yeah, Cosbella also says, I totally agree with the differences between a 2-star and a 5-star nursing home. So whenever you're looking at a patient coming in with like shortness of breath, fever, tiredness, you're worried about an infection, and they're also saying, oh yeah, by the way, our facilities also had a couple of other patients that were sick too. You're worried about a common infection there. So in the ED, he's ill-appearing and obtunded. Wow, so he's not doing too well, and he's like non-responsive and just kind of lying there. His temperature is 103, very high fever. Blood pressure is getting lower. Pulse is 68, and respirations are 26 a minute. So this guy is not looking great. He looks acutely ill. We got to make sure that he's getting better soon, or else he's going to end up in like that ICU setting too. Pulmonary exam is crackles in the left lung base. So thinking more of like a unilateral lobar pneumonia kind of pathology. I'm pretty sure I already know what it is. Bowel sounds are hyperactive and his abdomen is soft. No meningeal signs are present. All right, so we've got low hemoglobin, low hematocrit, pretty okay, but still low platelets. White blood cell count definitely elevated. Neutrophil count is definitely elevated too. Serum chemistry is hyponatremic. Which I feel like the test shouldn't have given you that. Potassium, okay. BUN, creatinine, maybe a little dehydrated. I mean, you don't know what his baseline is, but yeah, straight out of step 1. Low key kind of is. So low albumin, T-bill is a little elevated, and you're seeing a little transaminitis too. Chest x-ray reveals an ill-defined infiltrate at the left lung base. PIP-TAZ and VANC are started empirically because the ER was like, hey, this guy meets sepsis criteria. Can you admit him for sepsis? And then I'm like, sepsis secondary to what? And they're like, sepsis. It's not my job. So Dr. Saiken admits the patient, and it just said sepsis. So he just continued the antibiotics, but the patient continues to deteriorate. And the repeat chest x-ray shows that progressive infiltrates with worsening left lower consolidation. So clearly I did not do my job well. I just kept the same broad spectrum antibiotics on thinking they would work, and lo and behold, they did not work. And his lower lobe consolidation, that pneumonia, has definitely gotten worse. So the patient's condition is most likely respond to which of the following. So I think the people that were saying straight out of step one, this pneumonia is most likely Legionella. This is it can live in the water, I think. This bacteria can, and you usually see it in nursing homes, in like their air conditioning units or like their shared water dispenser units. Multiple residents can get sick. It's called Legionella because I think like this bacteria was first discovered at like a case of the American Legion, where a bunch of different veterans got sick too. So yeah. Let's go to ProCal just to be sure. ID consult. Oh my god. So yeah, we started broad spectrum antibiotics, but they didn't work because the way that you want to treat Legionella pneumonia is with levofloxacin. Generally, you don't want to give, a fluoroquinolone to an 82-year-old, but clearly they're not doing well and they're not getting any better, and you need to use the correct antibiotic and the correct weapon to target the correct bacteria. So I'm going to say Legionella in the water supply and levofloxacin. Do you agree?
Yeah.
Would you have kept him on broad spectrum for the same period if this were an actual case you were on?
No, I mean,
no.
I don't think so. No.
If I had all of this information from admission and the ER told me to admit him on Zosyn and Vank, like, I probably would have put him on Levaquin, like, on admission. Right? I mean, the ER is there, like, to rule out dangerous things, to stabilize acutely ill patients, right? They're not necessarily there to figure out what it is, right? It's not wrong of them to start him on Zosyn and Vank. But, I mean, yeah, obviously, he was continued on the same thing for 2 days and he didn't get better. So you're probably dealing with the wrong thing if you just continued it. Watch for exploding Achilles tendons. Yeah, definitely. Wow. Whoa. Wait, people said
interesting.
Oseltamivir, really? But it's literally screaming like even the hyponatremia too. How often have you ever actually seen Legionella pneumonia with the hyponatremia? Like,
no.
Even the left lower lobe pneumonia, isn't that exactly the lobe that it says on Sketchy with like the diagram?
Yeah, I think so.
Oh my god. Yeah, so it's the contaminated water supply. It does. Oh my god. Legionella in the water supply, giving levofloxacin, Colonel Mustard in the hospital. The only thing they didn't give us was diarrhea. Yeah, wait, why were they saying oseltamivir feeds influenza, which commonly shows bilateral reticular? Yeah, like it's viral. And there's like 3 other things screaming Legionella here.
I think maybe because if people thought, oh, they're not responding to antibiotics, like very broad antibiotics, must be viral then. Maybe that's
true.
where they get tripped up.
Right, yeah. Because it's like why wouldn't Zosyn get Legionella, right?
Yeah.
Oh yeah, ampicillin and piptazo are both beta-lactams that are ineffective against Legionella. Yeah. But yeah, I mean, I feel like after 2 days, like, you're probably on the wrong, antibiotic for this. Is Legionella and Legionnaires the same? Yes, Legionella what is it called? Legionella pneumophilia is the bacteria, and then Legionnaire's disease is, the pneumonia that causes. Legionella takes so many species from Floribacters and recent reclassifications. It made my textbooks outdated. That's funny. What were you gonna say?
I think that the going back to what we were talking about earlier, I think Zosyn being first choice may not be the worst option if you think about like healthcare acquired or associated pneumonia. They're trying to cover for Pseudomonas. So I think the ED starting that is not entirely outlandish or wrong, but absolutely, like 48 hours is way too long for you to just let them languish with the same antibiotic if they're worsening. Like, you should reevaluate usually pretty quickly and change course if they're not getting better.
Yeah, I saw a post on r slash hospitalist lately, like just some guy who was just like bemoaning the current state of healthcare and like lazy hospitalists because it was just like he was his family member or something was in the hospital, and he just wrote like, I straight up would not feel comfortable like leaving somebody like not medically aware alone in the hospital like this, because the hospitalist just comes in for like an hour, says all of their things and then leaves. Not even an hour, sorry. The hospitalist comes in for like 5 minutes, says all their things and leaves. Like doesn't even change the antibiotics, doesn't even change the working diagnosis and stuff. And it's like it's scary that like some management at some hospitals from some doctors really are like this. Like they keep you on the same antibiotics for 48 hours without even, thinking that the initial, diagnosis could be wrong or whatever. So it's just a case of, be better, right? Like obviously
Right.
like we're both in like academic systems, right? Like we have, very strong colleagues and everything to like remind us to like do things correctly, and there's a standard. But imagine you're at like a rural hospital somewhere, like a big community hospital, like you got 40 patients on your list, you got admin breathing down your back. Like maybe there are cases that like you let these get by you, and that's scary, right? Like, oh yeah, he's been on the same antibiotics for 48 hours, we'll see him turn around. Like, will you though?
Right. Right. And it's fair to think about how patients and their families may have had bad experiences before, right? To not like instantly judge, oh, they're being demanding, or oh, they want to take up more of my time. I'm already so busy doing work as a hospitalist, taking care of 20 patients. But, if they had a family member who had a really bad experience at a hospital, they could just be very concerned. And it's definitely something to think about that we don't always think about. For example, Saiken and I, when we were at our large academic center hospitals where we have a lot of resources, our colleagues are very intelligent, they're very active, proactive, they do their best to try to practice accurate medicine. Doesn't always happen to other people, and negative experiences absolutely can happen. To not pass judgment on those people for talking about this.
Microbiology guy here. Shouldn't a bronchial sample have been sent for culture on day one? I mean, realistically, in the ED, probably yes. I wouldn't say it's necessary for diagnosis, but yeah, it probably would have been sent by the ED. But then, the ED nurse probably didn't even get the sample, but the order is still there in the system. They're like, oh, patient didn't expectorate, blah, blah, blah. What game is this? This is American Board of Internal Medicine board review. So we're doing like our actual like board questions that you would take after 4 years of med school and 3 years of internal medicine residency. So this is like the fourth exam you would take, right? So step one,
Yeah, I
step two,
mean,
step three, and then ABIM.
don't forget the MCAT.
Oh, okay, the fifth exam. If you're gonna count the MCAT, well, you want to count the SAT? This is the sixth
Sure.
exam you would take. Board review DLC just came out. Yeah, no, it's just because it's like, dude, I kept playing Doctor Duel, and like Doctor Duel is fun, but like it's just not like when you're actually at the level of like an attending, like there's so many different things that are going on. Like it's just like I want more info to answer this question. And it's just like super frustrating when they just give you like a very generic blanket statement and you have to get like 3 things wrong before they actually give you like the information that you need to answer the question. What game is this? Boards.
Boards. Life.
Who's gonna do a bronchial swab on an 82-year-old? If you're at an academic hospital with like Palm fellows that are like, hey, I need another bronch before I can graduate. Like they're probably
Sign me up.
doing all those. Yeah. But then in a real hospital, the nurse is probably just like, oh, I couldn't get it. I had too many patients. And you're just like, oh, it's okay. Don't worry about it. I'll cancel the order. All right. We've been going for like two
All
and a half
right.
hours. You okay? You feeling good?
Yeah, I'm chugging along. I signed
right.
all my notes today. I don't have anything left I have to do.
Cool. So using socials like Reddit as a dentist, not that often. I don't know. I think that's just me. Like I followed like r/med school, r/residency, and now like r/hospitalist. So I think it's just like personally, like I use Reddit, but the only subreddits that I read are like relevant to my job or like League of Legends. Like I don't really like read like subreddits like for news and stuff.
Yeah, don't ever forget about the younger docs among us. You know what I mean? We definitely check on social media.
I thought you were gonna say we definitely play League of Legends.
Well, I mean, I play League of Legends too, but I wasn't gonna say it.
Yeah, dude, I was streaming my placements and you were like, oh yeah, I already have a great read on the meta. Like, Nautilus is super meta, right? I'm like, the patch just came
Oh,
out.
my
What do
my
you
five
mean?
stack was playing shit, and I was just like, I gotta join. It's hard to get a five stack these days. All right, we keep going.
Yeah, let's do
Right,
at least like another 30 minutes or something.
sure. All right, 76-year-old woman comes to the physician for routine follow-up. That's me. I'm the follow-up. She complains of frequent right knee pain and swelling that is relieved by daily naproxen, which is a medicine similar to ibuprofen or Advil or Aleve. It's an NSAID. She was offered knee replacement surgery for her severe osteoarthritis, but she refused. She was diagnosed with stable angina 5 years ago and has now undergone any coronary intervention that's like a stent or something to help open up or fix this kind of heart disease that we commonly call. She denies chest pain with mild exertion, but admits to occasional chest discomfort with moderate exertion, which can sometimes happen if you got a lot of cholesterol plaques in your heart. If you try to overwork your heart more than it can handle, you'll get pain and achiness, and you might feel out of breath or winded when that happens. Her other medical problems include atrial fibrillation, which is when the atria of the heart, the top two smaller compartments, don't beat in sync with each other and they kind of just vibrate instead. High blood pressure, high cholesterol, and diet-controlled type 2 diabetes. Her current medications include warfarin, which is like one of the oldest blood thinners that we've got. It's actually from a rat poison. And her target INR is 2 to 3, which is just, we have to check the levels or the coagulation levels in the body to make sure that.
Can we go back to the warfarin is not the rat poison like
I just glossed over it.
Okay, so
rat poison, guys.
There is a medication that was eventually used as rat poison because it would kill rats because it would make them suffer internal bleeding and die. But then, a much more mild version of that medicine, warfarin, is used to, help people not clot and die.
No, we just give people rat poison and it works. What doesn't kill you make you stronger, right?
Yeah, warfarin is, so I think rat poison is called like super warfarin or something. So like if regular warfarin is just like a blood thinner, then like super warfarin, rat poison, causes internal bleeding. Yeah.
Yeah. But she's doing great. Grandma's not doing so good. Well, actually, she's not doing too bad. She's on aspirin as well, low-dose aspirin, metoprolol, enalapril, and rosuvastatin. These are all medicines that help with heart disease and high blood pressure. 35-pack-year smoking history, not too great, but she quit smoking some point in the past. She's an ex-smoker, so kudos to Grandma. At least that was something she was able to do. Not easy, by the way. Her blood pressure is a little high. Her heart rate is 80. Her pulse is 80, but irregular, which is consistent with atrial fibrillation because the heartbeat is not really as regular because it's vibrating, and the rest of the heart kind of goes in tandem with pacers from the heart, so it can be irregular instead of beating in sync with each other. BMI is 42, which is quite high. That's, I think, class 3 obesity, and just how we class it based on how heavy you are. And then we hear a murmur, a 2 out of 6 mesoscalic murmur at the left sternal border, which could be a sign of either a leaky valve or because of the atrial fibrillation that's making it difficult for her heart valves to close in sync with each other. Her lungs are clear, and then the right knee, as we thought, because of the arthritis, is mildly swollen and tender. And then so far, we still don't know what the question is. They're just telling us how Grandma's doing. So I guess we'll keep on marching along. Her blood tests are here. Creatinine for kidney function looks good. High density lipoprotein, that's what we think of as the good cholesterol. If anyone remembers those old Cheerios commercials from like decades ago, that's what I tell patients. We saw the Cheerios commercials where it helps lower bad cholesterol. The LDL, the low density lipoprotein, is the bad cholesterol. And then the HDL is the good cholesterol, so to speak. Triglycerides are fats. And hemoglobin A1C is the test we use to look for diabetes. And the cutoff, usually a 6.5 or higher, is diabetes. And then if they have diabetes, usually we try to get them down to at least 7. We don't bring them all the way down because we're not that mean, but we don't have to, right? 7 usually is when we see that things are fairly well controlled. So what sounds like a pretty run-of-the-mill primary care patient, and probably saw the patient sometime today or something, or yesterday or something like that in my clinic. Which of the following medications would be most likely to benefit the patient? So if I see this patient in clinic, what would help them with their life in general the most? Would it be clopidogrel, which is one of the blood thinner medicines, the Clopey?
Clopey.
Gemfibrozil, which is a medicine help out with high cholesterol. Glyburide, which is a medicine help out with diabetes. Lansoprazole, which is a proton pump inhibitor to help out with acid reflux, or niacin, which is a B vitamin that can also sometimes help out with high cholesterol. So not very glamorous. It's not super exciting. It's not like the person who's in the ICU and is dying from a pneumonia or something, but kind of if I see someone for follow-up and they're kind of living life, how could I help with keeping them healthy instead of something bad happening? Kind of what primary care doctors do a lot all the time is how can we kind of optimize their health with a medicine or with a recommendation or a lab test or something like that. So I think the main things here that are important, she is quite overweight. Her BMI is 42. In terms of her blood tests, honestly, her blood tests look pretty okay. Her kidney function's okay. Her diabetes, her A1C is only slightly above her goal of 7. Otherwise, not too far away. And then her LDL, her bad cholesterol, 65 is actually really good. Her triglycerides are a little high, but hopefully, at least where I work, it's not. It would be considered increased or elevated. I think usually for that's like 125 or 140 or something like that. I don't know what the lab references say on your world saiken, if that's abnormal or not. But
I'm like
I don't think
really
it's that.
abnormal. Like 160.
160. Okay.
So it's not terrible.
No, it's not. Okay. So in terms of, we have to probably do some test taking here. Gemfibrozil for high cholesterol, high triglycerides. I don't think so. I don't think she needs that. Proton pump inhibitor. That's something to think about actually, and I'll get back to that about why. Glyburide for diabetes. Her diabetes is almost at her goal, and we actually don't usually use medicines like glyburide in older folks because it can be a risk for low blood sugar, which can be bad. It can cause people to pass out, or they might fall, or they might get dizzy. So we generally try to avoid glyburide, and her blood sugars are already so well controlled that we shouldn't go too hard with this. So I'm gonna say no to C as well. Niacin for high cholesterol. Again, her cholesterol is doing good, so I don't think we need E either. And then clopidogrel is a blood thinner, like an antiplatelet medicine that we usually do for particular kinds of heart disease, like if you have a stent or something. She has never needed a stent because she has not undergone that coronary intervention. She's already on a low dose aspirin for that, and plus she's already taking warfarin, right? That rat poisoning blood thinner that can be quite strong. And if we give somebody all 3 of these blood thinner medicines together, the risk of bleeding increases dramatically. It's honestly what we call triple therapy, which we do sometimes in the acute setting in the hospital that saiken has to deal with for patients who have like an acute heart attack and they get a stent and they need all 3 at once. But we generally try to stop 1 or 2 of them at some point in the next like few hours to months to years, because if we have all 3 at once, risk for bleeding skyrockets. So we generally
this is usually like a very specific time when like the patient has a heart attack and a stroke, like, and the bleeding risk and AFib or something, like, and it's usually like the neurologist is writing like an essay in their notes that justifies it, because like for anyone else the combination of aspirin, Plavix, and warfarin is probably way too much. So
yeah,
so
I think this is only one option.
Like I wrote in the chat, like, I think it's D, but the reason is really dumb. Like, it's not a diagnosis question. It's not a treatment question. I just think it's medication management, because she takes a daily NSAID and she refused surgery for her osteoarthritis, right? So in a 76-year-old woman, I just don't want her to get like an ulcer from taking a daily naproxen. And that's why I give her lansoprazole. Like that, it's not great reasoning, but also none of the other answer choices make sense, right? Like you wouldn't treat hypertriglyceridemia with gemfibrozil, like you said, glyburide, not the correct option here. Niacin, I mean, that's, again, you use that as like an adjunct thing, but I mean, her cholesterol is like pretty well controlled, and like she doesn't really need Plavix. So it's like, I mean, I guess it is lansoprazole.
It is lansoprazole, and it is exactly for the reason that you said, because she's taking naproxen every day.
Yeah.
I'm surprised only 61% of people got it.
Glyburide, niacin. Yeah, I mean, she's already on all the right stuff, and everything else is... Oh, here we go, yeah. So she's already on all the right stuff, and everything else is controlled. Current guidelines recommend switching high or moderate risk patients to a selective COX-2 inhibitor, or combining NSAIDs with a PPI or misoprostol. Lansoprazole is approved in the US for prevention of NSAID-induced ulcers. Additionally, patients should take the lowest possible dose of NSAIDs. This high-risk patient should be placed on prophylaxis, since she will likely require long-term NSAIDs for osteoarthritis. So, question, isn't the BMI index not the most reliable piece of data, or does corroborating with other results not make it so bad? Yeah, so BMI is not a perfect indicator of health. I mean, it doesn't talk about like your actual body composition, doesn't talk about muscle, right? It is a very quick and dirty, very dumbed down way just to assess somebody and things like operative risk, or, you know, risk factors going into different medical conditions. The biggest thing here why I think they talked about BMI is just to reiterate that she has osteoarthritis, right? So she has osteoarthritis of the right knee, and osteoarthritis is going to be that sort of wear and tear arthritis. This is like the grinding of bone on bone, leading to a lot of degeneration of the joint itself. And in this patient, she has so much weight being carried on her knees, like her entire body, with a BMI of 42, that she does have significant pain and significant degeneration from, you know, living like this and having all of this weight, you know, down on the joint space. And I really think that that's all it's trying to say. You know, like for clinical practice, like you're never making a decision based on BMI. Like it's always going to be BMI and like something else. Like, yes, you can use the BMI to support your clinical reasoning if the context allows for it. But it's not like I'm just going to calculate somebody's BMI and then decide to prescribe them something just because of the BMI itself. And especially for this question, it's being used just more to paint the context of why her osteoarthritis is that bad.
Yeah. And to also go into, I think the description for the answer had something interesting where it suggested you could switch an naproxen to a selective COX-2 inhibitor, which for those who don't know exactly the kinds of medicines that exist out there, the most common one's called Celebrex or celecoxib. The issue with that in this case, because that has less risk for a gastric ulcer, right? But the problem is it has an increased risk for cardiovascular events because it's almost like the opposite of aspirin, the way it works in that regard. So it can increase the risk for someone to have a heart attack or to have some kind of cardiovascular event. In this case, because she has coronary artery disease, she hasn't had a stent to fix that or take care of that. We would not want to do that because that can potentially cause a heart problem for her or a heart attack, and that would not be good. So it wasn't even an answer option, but you can see here with the answer choices, the best choice to try to mitigate her use of naproxen or an NSAID would be we have to give her a PPI. Even if Celebrex was an answer, it wouldn't be correct for her, but they didn't include it.
Yeah, they actually, Vioxx, is that the one that they had to take off the market? Because it was causing like heart attacks. Like it was perfectly fine as an NSAID, but the risk of heart attack actually went up if you took that medicine. So the entire medicine ended up getting discontinued.
Yeah, it was Vioxx. Yep.
Pantoprazole is better for psych meds, I think, though. Where's Lev? I don't know. I feel like that's one of those things where a psychiatrist could tell me, and then I'd be like, "Yep, sure, I'll change it." Like, consider using pantoprazole instead of esomeprazole because it helps with absorption of my, you know, risperidone better. And I'll be like, "Yes, Dr. Lev, I will. Thank you for your inputs."
Appreciate the Rex.
Yeah, I mean that's why we have, you know, different specialties, right? That's why we have different people on consult, right? For all of the things we know about internal medicine, like I do not feel comfortable like being a primary managing anything about psychiatry, managing anything about OB-GYN, all these different things. So live call for psych consult, honestly we could. It's okay. I might do something with Lev again too. I'm already doing something with Shiori again, so we'll bring all the doctors around eventually. Oh, is this one mine? Oh, it is mine. Okay. 36-year-old man with known HIV infection comes to the emergency department because of a 2-week history of malaise, so just generally feeling unwell, and non-productive cough. He has not been compliant with his HIV medications. He denies any illicit drug abuse, and he has never been hospitalized in the past. So, not being compliant with your HIV medications is a very big thing. I mean, you always want to make sure that patients are being followed up with in the ID clinic, especially after a new diagnosis of HIV. The big thing is that non-detectable means non-transmissible. So, in order to control things like spread and outbreaks, like you want to make sure that these patients are actively taking their antiretroviral therapy. And I will say, like, a lot of infectious disease doctors that work in that clinic setting, like, do everything they can to get these patients these honestly very expensive medications. And their social workers probably do a bunch too, because medications like Amtriva, name some other ones. It begins with a D.
Descovy.
Descovy, right? Like these drugs, highly active antiretroviral therapy. Like these drugs do so much in preventing the HIV virus from replicating inside somebody and controlling the spread of HIV from a patient and their partners, that like if you do not, or if you just let the patient like slip through the cracks and you don't follow up with them and suddenly the viral load comes back in like the hundreds of thousands or the millions, like that is actually a very bad thing. Not just, from like a personal perspective where, yeah, their CD4 count is probably going to tank and they're opening themselves up to a lot of different opportunistic infections, but also just like on a public health level too. All right, his temperature is 102. Okay, that's pretty bad. Blood pressure is 122/70, and pulse is 112 a minute. So he is sick. His O2 is 90% on room air, so not terrible, but not great. His BMI is 23. His SCM muscles are prominent bilaterally with each respiration. Is that just talking about how cachectic he is? His SCMs are prominent bilaterally with each respiration. That's just...
Maybe it's like accessory muscles.
Oh,
or at least some
is it?
indication of that.
Okay. Yeah, I was like, why would you say his sternocleidomastoid? That's so specific. Like, well, his neck is bulging each time he breathes. Cardiac exam reveals tachy without any murmurs. Scattered rhonchi are heard on lung auscultations, and his abdominal exam is within normal limits. All right. So he's got a low white count, but in the context of infection, in the context with somebody with HIV, probably normal. Low platelets. Creatinine, okay. Sodium is fine. Potassium's a touch high. Glucose is okay. Calcium's fine. Chest x-ray shows bilateral patchy interstitial infiltrates. IV fluids and high-dose IV Bactrim are started. The patient should be specifically monitored for which of the following. Okay, well, this is just like a first-year med student question. All right, so this has nothing to do with HIV. This patient probably has a terrible CD4 count below 200 that makes them susceptible to PCP pneumonia or PJP pneumonia, pneumocystis jirovecii pneumonia, which is where they're getting this bilateral patchy interstitial infiltrates from. Like I said earlier about opportunistic infections, there is like a whole host of infections that you can only get when your CD4 count is, less than 200, less than 100, less than 50. You're thinking things like toxoplasmosis, cryptococcus, what else? PJP pneumonia, I don't know, disseminated candidiasis. Like there are only like certain things that you think of like about that. So bilateral patchy interstitial infiltrates, like you were thinking PJP pneumonia. He started on IV Bactrim, and yeah, so if you've ever been in a hospital that you get to round with a pharmacist as part of your rounds, they will talk about how Bactrim causes a type 4 RTA, a type 4 renal tubular acidosis, which causes hyperkalemia. Don't ask me the mechanism of that. This is just a random thing I remember getting pimped on in residency. And damn, the pharmacy man told me about that. And this is the correct answer. I don't know how to apply this to my clinical practice at all. I mean, it's just like, okay, give them Lokelma, give them Florinef. I'm surprised this is on boards. Like, this is like a step 1, step 2 question.
Yeah, I mean, we get like routine labs all the time anyways for people in the hospital, so I think it's a little bit moot, but like in practical senses, you're going to find out anyways. But I guess it's trying to say, don't forget that Bactrim can cause problems, and this is what you need to watch out for.
I do not remember TMP SMX at all. Oops. Yeah, it's definitely not like a common one. You have to worry about sulfa allergies, G6PD deficiency. Um, Sometimes, like when you're treating a UTI, if it's E. coli UTI, Bactrim might be a good option there because it's not like a commonly resisted one, like I don't know, Cipro or something. But yeah, it's. Did they even talk about it here? Distal tubular epithelial cells. Yeah. So this is a type 4 renal tubular acidosis. But I mean, there's not even like a teaching point here. It's just it is what it is.
We do use Bactrim quite a lot outpatient though for because it covers MRSA. So we don't have access to IV bank in the outpatient setting in urgent care. And if you have someone with a purulent cellulitis and the risk for MRSA is quite high in those situations, something we can reach for would have to is Bactrim based on what susceptibilities exist.
Yeah, I love antibiograms because it's no matter how much you think you know, and no matter what you think the right antibiotic is, they'll tell you to consult the antibiogram, and then it'll be like, oh, I actually have to use Bactrim for this one.
Yeah, exactly.
Ooh, SJS from Bactrim, scary. The only dermatologic emergency. The only time you're allowed to page derm overnight. I remember it can cause SJS, but don't remember the other side effects. I think I really only know this one because I had it in an ICU patient. So I had like, yeah, I think it was respiratory failure from PJP pneumonia actually. So he was intubated, young guy, HIV positive, not compliant on medications. So we had to give him Bactrim, and even Lokelma wasn't enough to bring his potassium down. So we also had to put him on Florinef and also a glucocorticoid for blood pressure support. But he ended up fine. We extubated him. We got him on the floor. Hopefully he followed up with his doctors after that. Cool. I feel like I keep getting easy ones. Like it's not like the percentages are easy, but I think it's like the way I answer them, it just makes too much sense to me. We're 100%. Like we're 12 for 12 right now. Like I did not think that would happen.
Me neither.
Maybe it's just because I'm sitting here with you.
Oh yeah. You give that.
Yeah,
star
your
doctor
knowledge is
here.
just like washing off on me through Discord.
All right. Well, we're gonna see if this breaks the streak or not. I hope not. 45-year-old woman comes to the physician because of frequent urination for the last 6 months. She states that she has been waking up several times at night to urinate. These symptoms also disrupt her professional work schedule. She's been taking lithium to treat mood disorder for the past 5 years. Where is Lev? She has tried many other drugs for her mood disorder, but none have been as successful as lithium. So unfortunately, she has to take it.
He has to be on lithium.
Yeah. She's adherent to her treatment and has her lithium level measured regularly. She has one episode of mild lithium toxicity 2 years ago. Her physical exam is fine, and here are the labs. All right, kidney function's not doing so great. And then the urinalysis, we got trace protein, but everything else looks normal. Right? Oh, there it is. There it is. Water deprivation test. So what happens when you are given, what happens to your urine osmolality? Okay, now we have to explain osmolality, which is like one of the most confusing things to try to explain.
Now I have to type in AAFP hyponatremia. Pull up the one diagram I've been looking at for the past 4 years. Oh my god, here we go. This?
So
it is this.
There we go.
Go ahead.
There we go. Oh my gosh, we love sodium, everybody. Our internal medicine doctors love sodium. Dr. Glaucomflecken was absolutely correct. So this is an example. Actually, did they even give us the sodium?
Oh wait, did they? I don't think they did.
I don't think they did. No,
oh, shit.
They didn't give us the sodium.
Oh no!
So I think we can't use this. We can't use this. So the answer here, this is like a step one question. It's like very pathognomonic for what we're going through. Lithium causing people to diurese a lot, to urinate a lot. It's very specific. It is nephrogenic diabetes insipidus, which for people who don't know what that means absolutely nothing. But what basically happens is that the lithium messes with the kidney cells that are supposed to be responsible for reabsorbing water, right? Because of that, your kidneys dump water. They just dump water. They don't respond to your body's natural feedback mechanisms in order to tell it to stop dumping water and to reabsorb the water back into the body. So you just pee constantly, and it doesn't matter how much you drink. If you stop drinking, or if you do drinking, if you are drinking water, the medicine, the lithium, is causing problems. But the problem is that it's not the only thing that can cause this diabetes insipidus, right? There's also what happens if your brain stops telling your kidneys, hey, please reabsorb the water. So your kidneys think, oh, I should just dump all the water then, right? That's called central diabetes insipidus. And that's because the brain's not doing the job versus the kidney not doing its job. In order to find out how to do, or what the cause is of each of these, we have to do a specific test called the water deprivation test. It can be done a few ways. I'm actually trying to remember exactly the way they're describing here, because they're giving DDAVP.
Right? Like, that's not a water
versus...
deprivation test. Like, you do the urine osm first, and then you deprive them, and then you do the urine osm after. Right?
Let me see, actually.
Where's
this is a little bit... yeah. This is a medicine thing, though. We should know how to do this, but we're blanking on this.
Well, I can do it. I just don't want to do the mechanism of action.
Yeah, I'll try to help you there.
All right, so we have urine osms of 300 at baseline, and then after you give desmopressin, which is an arginine mimetic, I think. So it does what vasopressin would normally do. It did not really change the osms, or like it's slightly... I can't wait. Is 325 significant from 300? Like, I don't even know, actually.
No, it's not.
So it's unchanged, right? So it's like it's not responsive to DDAVP because it's not nephrogenic DI.
Okay, here we go. I got it. I have to remind myself.
Jeez.
By the way, this is the issue with being an attending doctor is that we have access to look up resources now, unlike students or residents where you have to memorize stuff for tests. So, we kind of dumped all the stuff from our brains immediately after we took this test, because we're like, we can just look it up if we need to remind ourselves of a particular mechanism.
Oh my God, who said we were going to jinx ourselves on this one?
I didn't know. Well, we got the right answer, right? We're going to get the right answer because we know what it is.
We know what it is. I just don't know how it is.
Right, the mechanism, like the nitty gritty details, which, ultimately, do the patients care if you can explain them the mechanisms or not, or do they care if you get the right treatment for them and they feel better?
Yeah,
probably more the latter. But I mean, people aren't wrong. We should still know this. So long story short, after having to remind myself about this, DDAVP, or desmopressin, it's like a synthetic analog of vasopressin, which is what our brain naturally secretes to tell the kidneys, hey, please reabsorb water, right? If your brain's not making enough of it, then you're low on this. So if you give someone an analog of it, then they'll get better because they're just missing the signal from their brain to tell the kidneys to do that.
But
Whereas if their kidneys, yeah, exactly, it didn't get better because their kidneys are the ones that are at fault. It's not the brain. The brain's doing its job secreting this vasopressin, but the kidneys aren't responding to it, which is actually why I think they changed the name of nephrogenic diabetes insipidus. Actually, they call it like arginine vasopressin resistant diabetes insipidus. That
sounds familiar. Yeah.
Yeah, versus like arginine vasopressin deficiency, but it's kind of like a semantics thing. So in this case, right, what would be the treatment for the patient? Should we give them DDAVP if they didn't get better with DDAVP? No, we shouldn't, because it clearly showed it doesn't work.
Yeah.
Yeah, the answer is amiloride.
So amiloride works on the ENaC or the collecting duct somewhere? Like, I got it right. I just don't know why. Hang on. So, where is the answer? Here we go. Patients who cannot stop lithium should be treated with salt restriction and selected diuretics. Amiloride blocks sodium channels in the collecting ducts to prevent lithium's cellular entry, while thiazides combined with sodium restriction promote a mild hypovolemia that acts to increase proximal sodium and water reabsorption. However, serum lithium levels increase with both options and require close monitoring. Yeah. So it's like I don't know if you noticed, like I scrolled down and I had DDAVP and then I was like, wait, but the DDAVP didn't work. So then I switched it to amiloride. Yeah, like it's like one of those things where it's like we know what's going on and we're attendings now. So it's like we don't know the nitty-gritty details anymore. Like we know what the right answer is, but it's like unless your patient is like a nephrologist and they're pimping you on how does this medicine work, like you probably don't remember this kind of stuff off the top of your head. So a lot of people in the comments kept glazing us. They were like, wow, I can't believe you remember all of this. We're like, no, we do not remember all of this.
Secret is we don't remember all of this.
All right, well, I give myself credit because I knew what the right answer was. I just could not explain this whole actually, you know, I got it. It was a ENAC channel thing because I knew like it had to be like blocking this. You know what? I'm gonna give myself that one.
yeah, we got the right answer.
Yeah, we got the right answer, and I named like 1 or 2 facts about the correct answer. I like how I immediately jumped to the AAFP hyponatremia chart, and then you were like, wait, they didn't even give us the sodium.
There's no sodium.
We love
it's just a reflex
sodium.
for you.
Oh man,
Patients got sodium, and we love sodium.
This is how you know we're at the 3-hour mark. Oh my god. Okay. You want to do one more each?
Sure.
Go from
Let's
there.
do it.
All right, bet. Oh man, yours gets to fit on one. Boo.
Uh-oh. Okay.
Oh, this is heinous. Oh god.
I think we may have met our match here. Let's see. 40-year-old man comes with history of end-stage renal disease. Comes to the office, my office, for routine follow-up. He's been on chronic hemodialysis for the last 3 years, so quite a long time. The patient's parathyroid hormone and alkaline phosphatase levels have increased progressively, despite efforts to maintain normal serum phosphorus with phosphate binders. Okay, there's a lot to unpack here, but basically part of what happens is that as you have end-stage renal disease, if your kidneys don't work at all anymore and you need dialysis to take the job of the kidneys, you have issues with regulating your calcium and your phosphate, right? One of the reasons is because kidneys dump phosphate. And there's also signaling involved with the kidneys on how your body secretes or reabsorbs phosphate and calcium from your bones. And that's where parathyroid hormone comes in. Alkaline phosphatase is a enzyme that is supposed to help break down bone potentially, right? So the levels can be elevated because if your levels of calcium or phosphate are high or low and need to be adjusted, then your body normally is supposed to break down or build up bone to either increase or decrease the level of these respectively. And if things don't work out well because the kidneys aren't working, then it can slowly after years go out of whack, and that can cause problems. So we got a set of blood tests here to look at these levels, right? Creatinine super high because this patient has end-stage renal disease, their kidneys don't work. Calcium looks fairly okay. Albumin is 3.4, so just a smidge low, but really not that low. But the alkaline phosphatase is super high, 320.
I don't
remind myself phosphorus
off the top of my head.
I think it's high.
Phosphorus
it is
high.
5.1.
And then parathyroid is
PTH is definitely high. Yeah, 700. I think you passed it earlier.
Oh,
right there. 10 to 65.
Definitely high.
It's like 10 times higher.
Oh, and
then vitamin D.
OH. Jesus. Oh my god.
Vitamin D is normal. Low would be like, I think, if they're 20 to 15 or so, because I see it pretty often.
Oh yeah,
they say here.
You actually do, right? Yeah.
Yeah.
Dude, I don't even know where it is on this thing. D-dimer.
D-dimer.
25. Oh my god.
There's no search function here.
No, it's not. Wow. I don't know where
we can't find things, everybody. Chat, we can't find things.
Oh, here we go.
There is. It's the last one.
Oh, okay. So
there you go. Okay. Yeah, it's normal. All right. Adding cinacalcet, which is a the phosphate binder to this patient's regimen would most likely contribute to which of the following? Oh gosh. Okay.
Jesus Christ. Okay. So I mean, it's like most likely to contribute to which of the following. It's like those questions where it's like the patient has like, you know, a busted hip and they need hip surgery, and it's like, which of the following is most likely to happen to this patient if they don't get the hip replacement? And they're like, the patient dies of loneliness, the patient gets depressed, the patient, like, I don't know.
All right, let's see if we can like test take our way into this, because I also don't know 100%. Like I could probably feel which ones sound the most reasonable, but I don't know 100%. You'd have to look this up in like a database to see how patients actually respond on like a nation or international wide level. And I don't have that ability in my brain, so I can't tell that off the top of my head. But let's see here. Decreased need for parathyroidectomy. I think that's possible, right? Because trying
that
to
sounds
reduce
like a
the
good
phosphate
reason, right? Because you're trying to. Okay, cinacalcet is a calcimimetic, right? So it's like calcium, right? Because the whole point is you're trying to make the parathyroid shut up, because right now the parathyroid is secreting so much PTH because it's trying to trash phosphorus and it's trying to resorb from calcium from bone. So if you give cinacalcet, the cinacalcet exists as a calcimimetic in the blood, and the parathyroid is like, oh, okay, there's enough calcium here, I'm fine, and it'll calm down.
Right.
So I think A is valid, yes. What is osteitis fibrosis cystic?
Osteitis fibrosis cystica, it's when because your alk phos is so elevated, right, and the PTH is so high, telling the bones to break down because it's thinking, oh, calcium's so low or phosphate's too high, then it causes like small cysts to form in your bones because you're breaking down the structure.
Ew.
That's normally supposed to exist. Yeah, that's what cysts, I think. I mean, the name implies that.
Okay. Wait, but so basically this would be no, right? Because you're adding cinacalcet to prevent this from happening.
Right, exactly.
Okay.
Exactly. So I think it's not B. Overall survival, though, is a little tough, and especially because like when you get into like very big, vague, like mortality survival metrics, it like things don't usually do that. They're not like powerful enough to do so, right? And I guess when you think about like, can this medicine that helps with calming the parathyroid hormone down, can it actually make them live longer?
But what if it does?
I find a hard time to justify that. I know, right? That's the thing.
Like,
C can always be possible.
Like these mortality benefit questions, right? Either it is mortality benefit or it's not mortality benefit.
Right, exactly.
Like it's either like ding ding ding, this is the correct answer, or like ding ding ding, it's obviously not the correct answer. Nobody would ever say it prolongs overall survival. Like we were for heart failure one, I was saying GDMT. Like diuretics are actually not a pillar of GDMT because there's no mortality benefit. But obviously you still give diuretics because like they make the patient better.
Right, exactly.
Is cinacalcet the one that is like the GDMT for secondary hyperparathyroidism?
GDMT of this particular disease. I'm gonna
this is
guess
nasty.
No, but
yeah,
totally be it. Yeah,
I mean it's valid. I think A probably is the strongest one so far.
Yeah, because it's definitely not D, because it doesn't, the calcium doesn't really interact with cholesterol plaques necessarily. I mean, I guess there are calcified cholesterol plaques, but I don't expect it to impact cardiovascular events.
Unless it does.
Unless it does.
Unless it does.
It's all the above. And then symptomatic hypercalcemia. I guess if you're calming down the parathyroid.
But it's a calcium analog, so it wouldn't.
Right.
Unless it does.
Unless it does.
Oh, this is so bad. Dude, when's the last time you added cinacalcet to anyone? That's not my job.
Never. Yeah, that's not my job. Nephrology, please.
I'm surprised I remember how cinacalcet works, to be honest.
I forgot at first until you reminded me. I was like,
what's the brand name?
Sensipar?
Sensipar.
Is it Sensipar?
Yeah. Jesus. Yeah. Like I never.
Yeah. I can't believe I remember that. Oh my gosh. I just see it in the medicine list. I'm like, oh,
yeah,
your kidney doctor puts you on Sensipar. Great.
Yeah, right. Like, oh, your kidney doctor puts you on Sevelamer. Okay.
Yeah. Continue to monitor.
I'm gonna say C and D either both have to be true or both not true, and therefore it's A.
I like your thinking. Let's go with A. Final answer.
Oh my god! Wow.
Ooh. Oh my gosh. Okay. We got it.
Oh Jesus Christ.
We logicked it out.
we really did. Okay, yeah, no, but I guess cinacalcet works the way I thought it would, right? Yeah, so you have a persistently elevated PTH, and your PTH is saying trash phosphorus, give me more calcium. So you add the calcium mimetic, and it allows the PTH to go back down because it senses that there's enough calcium in the system. And if you don't have enough calcium, then you just give them vitamin D so that they absorb more calcium instead. Huh. This is dude, only 43% of people got this correct.
Right?
Wow, that was definitely a hard one.
Somehow more people got this right than that question we had earlier, right? That we thought was like super straightforward.
Which one?
I think it was not that one.
We've only done like 20 questions, 10 questions.
Wasn't there one that had like a 30% correct rate? There was something.
Really?
The one of the questions I felt like was not
62, 72. Oh yeah.
Yeah,
well,
37.
The reassure. Yeah, okay. I will say though, definitely it's a sampling bias when you do one of the questions that's like reassure, do nothing. But yeah. Okay, I definitely would not have gotten this had I not just randomly remembered what Cinecalcid does.
yeah. I would have to made a flashcard and be like, what is Cinecalcid's mechanism to remind myself?
Oh my god. All right. We've done 13. We should do 2 more. Okay, this one's quick. This one's quick. Okay.
Ooh.
Oh wait, is this malaria? Okay. Yeah, let's do 2 more. I'll do both of them. How about that? All right.
If you want to, I'm happy to do one more.
36-year-old man comes to the travel clinic prior to a safari in East Africa. He has a history of intermittent asthma and he takes albuterol as needed. No allergies. Physical exam is unremarkable. He wants malaria prophylaxis. Tovacone. Don't worry about it. It's a Tovacone. I mean, okay, 94%. There we go.
Nice.
Somebody asks what application or website it is. This is a internal medicine board review. Undisclosed brand. An undisclosed name. Don't worry about it.
Don't worry about it. It's totally
Don't worry about how I obtained access to this or what it may or may not cost the average consumer. Like an actual exam, don't worry about it. Oh, no, what the?
oh no.
Wait, do you want to do a biostats one? Actually,
I can give it my best
this
shot.
is a definition. This shouldn't be that bad. There's no calculation.
Yeah. Let's see if I remember this. All right. Study evaluates the role of MRI in assessing the potential for myocardial recovery after reperfusion. A total of 185 patients undergoing coronary bypass surgery were evaluated by MRI for delayed gadolinium enhancement and indicative of myocardial scar tissue and therefore no viability. Subsequently, the patients were followed for improvement in myocardial contractility after surgery. The following results were obtained. There is this 2x2 diagram here. So I think in this situation, this is like the sensitivity, specificity, predictive value test characteristics that you learn as part of biostats, perhaps even before medical school or during medical school, that unfortunately are still relevant for you even after you graduate from med school.
And by learn, you mean you learn it like the week before your board exam, and then you forget everything. And then for step 2, you learn it the week before the board exam, and then you forget everything. And then for step 3, you learn it the week before the board exam, and then you forget everything.
I literally DM'd you like before the test, and I was like, "Hey, dude, how are you going to study for biostats?" And you said the exact same thing as you just did to me.
I learned the biostats. I forget the biostats. Dude, it's so unnecessary.
Yeah, I agree.
Oh my god. Okay, so
all right.
A,
so I think the important
B,
thing is
C,
just
D,
figuring out,
and you just got to remember what specificity is.
Like what's the Z's and what's the test positive. If you can figure that out, then you can use like the ABCD 2x2 diagram, and it's pretty straightforward. But if you mix the 2 up, then the numbers become wrong. And I bet the question options are gonna have one of those where it's if you mix the 2 up.
So so it's disease is on top, and I put positive on the top left and negative on the top right. So yeah, I think no contractility recover. Wait, so we're evaluated by MRI for delayed gadolinium enhancement.
Yeah, so that's a test, right? That's a test, and the disease is contractility.
So test positive, test negative, and then no contractility is negative? and then contractility recovered is positive?
Let's see here.
Oh wow, wait, this is annoying. Because like I feel like the answer, if I set this up like a normal table, specificity should be 82 over 82 plus 3. But now I don't know if this table is set up normally.
Right,
Yeah,
exactly. That's how
Smiling
they try to
Archives
trick you.
says the same thing, right? I think it's 82 over 80. Yeah, but I don't know. Sensitivity would be 92 over 100. Specificity should be 82 over 85. Positive predictive value should be 92 over 95. And the negative predictive value should be 82 over 90. Right? But
Yeah.
So-
Let's see. I guess what's the disease and what's a positive disease and what's negative? Because
positive disease is no
scar tissue.
contractility recovery, right? Because they're positive for the disease. Wait, dude, what are they asking? What? Okay.
Yeah.
They're already
They-
undergoing cabbage.
Yes.
They are already going cabbage, and the test is MRI for delayed Gatto enhancement, meaning no viability. So if they test positive for the Gatto, then they don't even undergo cabbage?
No, I don't think so. I think they're saying if the test, if Gatto is present, then true positive should be they have no viability, right? And then a false positive is they have viability despite having positive delayed Gatto enhancement.
So then why is the disease written as contractility instead of viability?
I have
God.
no idea.
What the
I have no
fuck?
idea
Dude,
why
I
they
hate
worded it that way.
biostats. All right. Kev's on keyboard says gadolinium present equals scar tissue and no viability equals no contractility recovery. No viability is no contractility recovery.
Yeah.
Yeah, that's
So then
what
the
I'm
true
saying. So
positive-
so
Right.
patients being followed for improvement in myocardial contractility after surgery means that if they got no viability? Okay, wait. Jesus Christ. Okay. The disease is positive if they have no contractility recovery. That's because they have scar tissue.
Yes.
So even if you do surgery on them, they won't recover.
Yeah.
So that is
no
disease
recovery.
positive. And if you do
Okay.
surgery on them and they recover, then that's disease negative. The test is Gatto enhancement. If the Gatto enhancement is positive, that means that there is scar tissue and it's not viable. And if it's absent, that means there is no scar tissue and they should improve after surgery. Yeah, so I think this is set up correctly. So it's disease positive, disease negative, test positive, test negative. Oh my
The
god.
specificity would be
So it's
would
82
be
over 85.
True negative. Yeah, exactly. True negative over true negative is false positive.
Please do not let the
Please be
only
right.
question that we get wrong be a
biostats.
goddamn biostats question.
Oh my gosh. Okay. Okay.
Oh my god. Yeah, you'd probably. Yeah, okay. So Aaron Does Thinking says it is 82 over 85 because the three that recover without, or the three that did recover with delayed Gatto enhancement present are your false positives.
Yes.
Right.
Yes.
So yes. Wow, 49% correct. That's crazy.
Yeah.
I mean, this is
wow.
just like a. It's not even a definition question. It's like, one, do you remember the contingency table? But like, two, do you set it up correctly by reading the question correctly?
Yeah. Can you understand what they're trying to tell you? Because we couldn't for the longest time.
And this is, yeah, dude, how long did this take us? Like 10 minutes?
Yeah.
Like, what the fuck? Like if you were on the exam, like I probably would have gotten this. Honestly, no. Actually, if I was rushing through this, I would have just assumed the table was set up correctly. So then I would have
Right.
just done it normally.
We overthought it so hard on this one.
I know, right? Like, it's the fact that we were able to debate it, and then the table ended up being correct anyway. Like, Jesus. Wait, so do the IM boards actually have biostats? Yes, yes. So
Yes.
step 1 has biostats, step 2 has biostats, step 3 has biostats, IM boards have biostats. I learned it 4 times and I forgot it 4 times. Like, just it's low yield, but it's free points, right? Like you will get a biostats question on your boards, just straight up, you will. But I mean, it's the same exact stuff that you've learned since M1 year. So like it's just learn it, right? Pump it and dump it, like forget it a week after. You'll never need to use this stuff. But I don't understand the thing with the table being correct. Please educate me. So the way you want to set up a contingency table, like a normal 2x2 contingency table, is you want to put the disease on top, and you want to put positive on left and negative on right. And then you want to put the test on the left, and you want to put the positive on top and the negative on the bottom. And based on that, you would want to create your matrix where A is positive positive, B is positive negative, C is negative positive, and D is negative negative. And then you just have to go through your, formulas. So sensitivity being A over A plus C, specificity being D over D plus B, positive predictive value is A over A plus B, negative predictive value is D over D plus C, odds ratio is like AD over BC, relative risk is A over C plus, it's just stupid. Like, again, you do not need to know this to be a doctor, but you do need to know this to get free points on your board exam.
I mean, some doctors do use it. Like I was telling you earlier this year, one of my
you use the
older
normogram or
like,
something, right?
You can, but like there was one of my colleagues like is like a big shot when it comes to JAMA. He is responsible for like commenting or looking through guidelines and things and how sensitive or specific certain guidelines are and things like that. He was like, hey, JF, do you want to write some guidelines for something for JAMA, which is the Journal of the American Medical Association?
Damn.
And me, being a very naive, fresh-faced attending, was like, heck yeah, please sign me up. And what followed was like the worst 2 months of my life trying to uncover what the heck these surgeons were talking about. No offense to Shiori, but I was
plenty
like,
of offense
what
to
are these
Shiori.
numbers?
Extreme offense to surgeons.
I was like, what are these numbers talking about here? And I traced it all the way back to a letter that was written to some doctor in Sweden in the 1990s.
Oh,
and
yes, I remember this story.
All it said was, trust me, bro. The doctor from Sweden said they did this.
In a personal communication?
In a personal communication, which for those of you who don't like write manuscript papers for science journals, is like completely untrusted. You're just like, literally, trust me, bro. I talked to the doctor who did this, and he said it's true. No like background, no like testing, no evidence. And I'm thinking, how am I gonna tell all like thousands of doctors who read this very prestigious journal,
JAMA,
the foundation,
right?
JAMA, that the foundation of this guideline from this surgery society is some guy said, trust me, bro, in 1990. How am I supposed to say that? Make it make sense. So yeah, some people do use these numbers and this math and everything like that. I'm not a big fan, but some people I guess like to do that.
Jesus. Wait, actually, Hika is here. Hika, did you have biostats on your RADS boards? Because like, honestly, I was surprised when they were on IM boards, but we did have to learn it like as part of our like normal research class, like didactic in residency. So it wasn't like completely out of the question that I would need to relearn it. But like, do radiologists need to do it? Because like dude, can you imagine putting a surgeon through biostats? They'd bite your head off.
Oh.
Oh my god.
You should ask Shiori about that. Biostats.
I can't ask Shiori dude, it's like it's a surgical specialty in the Philippines. Like, do you know how many like leaps we have to go through in order to like correlate our clinical practice? Dentists also have biostats course. Oh my god. Jeez. Actually, yeah, so like it's basically CCS cases. I think it's some kind of like different resources that like international med students use, but she sent me this thing and she's like, do you want to do these clinical cases? Because like, to be honest, I don't think I know how to do them. I don't think so. Man, you're so lucky.
That's so lucky.
Jesus. All right. You wanna call it here, or do you actually want to do one more?
I think we can call it here. I think we've gone through a lot. We don't
All
want to
right.
tarnish our perfect record, right?
Yeah, 15. Like 15 is a good like 15 out of 15. 16 out of
Yeah.
16 is just like an even number for no reason. You might as well just do 20 at that point, right?
You might as well do all 60.
Pass. Oh my god. Dude, this seems like my thing, the numbers. I mean, I don't know why it's a thing. It's just it's there for some reason. You know, it's again, like you learn it in med school for step 1, you forget it. You learn it in med school for step 2, you forget it. You review it again your intern year for step 3 and then you forget it, and then for some reason it just rears its head around on the board exam after that. And you're just like, god, everything sucks.
Yeah, it's applicable in some cases. Like if you have to explain to a patient, oh, this test has like a 90% positive predictive value. So even if the test result is negative, you know, I still think that if the pretest probability, if my suspicion for your condition is high, then maybe the test is not as helpful as if it were 99% positive predictive value. Like there's some utility that you could try to explain to patients. And if you have a patient in front of you who's like, doctor, I want the numbers, please tell me the numbers because I want to know what you're thinking about, it can be helpful. But I think practically a lot of times patients don't have the understanding, and that's not their fault, right? This is like very technical stuff.
I don't even
And if
have
you
the
can,
understanding.
right, exactly. I don't think about this too all the time either. But if you were able to like wrap that in a way that patients can understand, that's good enough for most people. And you don't have to necessarily get into the weeds about what do the numbers actually mean.
Cool. I mean, we don't have to do questions. Like, do you want to hang out? Just talk to chat. Talk about
Yeah.
talk about life,
Hi, Chad.
or just answer stuff. In med school, we had like 1 week of radiology elective. I'm gonna be so cooked for residency. I mean, you learn by the time you get to residency, you will basically relearn everything you learned in med school. The biggest thing I always tell people is like you learn more in your first 4 months of residency than the 4 years of med school. Really, it's just not even comparable. Like how different the grind is, and it's like actually usable information, like the real world context of how you use these medications, how you order these tests. And not even to say it like if you're in a surgical or procedural subspecialty or something, like obviously like you're going to learn so much more about operating than you ever will during like a surgery rotation in med school. So
Yeah. I think the biggest piece of advice that my program director, who actually this year he is retiring after I think like 20 years as PD for our program, but like the first thing he said to me and the rest of my class when we started residency as interns was, don't worry about remembering any medicine you learn from med school. You'll learn it. That's okay. But the biggest thing is that you're willing to get your hands dirty and like start remembering, start learning, start making notes, start learning how to be a resident, how to be a doctor, because that's the practical stuff that med school isn't supposed to teach you, but you'll have to learn on the fly because you'll be taking care of real patients, putting orders in and doing all those things, right? It's no longer what's the most educational thing. It's how do I take care of this patient who's sitting right in front of me?
yeah, because doctors like in med school, it's basically just college. Like that's why in most like other countries besides America, like in India or in South Korea, like med school is just 6 years of undergrad, and you do like courses, and then you actually do like the hospital work. It's much different than like what nursing students go through, where you actually jump into the hospital floor like day one. You learn how to hang medications, how to interact with patients, like how to actually take care of patients. Like a lot of med students might not treat a single patient until their third year of med school, because that's just how the curriculum is set up. Like you don't know anything about how a hospital functions, like what daily rounds are. Like when I was on my first rotation, like we were rounding, and I asked the resident, I was like, do we round every day? Like, is this a normal thing? So it's just they just don't teach you that stuff in med school because it's not the focus. Like med school is really just for learning things like pathophysiology, things like pharmacology, things that you might not even touch like 5 years into your clinical practice. But in residency, that intern year, that's when you actually just get all of the knowledge, like, oh, this is my job in a hospital. Like, this is what I am supposed to end up doing.
Yeah, it's like, honestly, I joke about this to my non-medical friends, but part of my job as a primary care doctor is essentially to be a retail worker. It's like, how do I respect your concerns? Maybe also try to get in some of my concerns too, in a way that doesn't take up too much time or offend you or dismiss your concerns, right? But a lot of times patients come in with questions they have, which is absolutely fair, but we have to balance some things, and it's very much so like a patient or a person facing job than like a book learning flashcards kind of job, right? How do you navigate someone who's upset, who's frustrated that they're like 30 minutes late? How do you navigate maybe the MA who wasn't as respectful to the patient, right? How do you navigate the consultant who's being mean to you because they think you're wrong? Like a lot of this is interpersonal stuff that in med school you don't have to deal with because you're not supposed to. That's not the goal of medical school. But once you jump into residency and beyond, that's your job. That's what you have to do. And that's where you really start to learn it, is when you start to be a resident.
And then when you're an attending, you really realize it's a customer service job. Like, the way a hospitalist like me gets recognized is based on my Press Ganey scores, right? So a patient who's under my care, like I save their life or bring them back from the brink of death or whatever, they grade me on a survey. Like, one, even assuming that they fill out the survey after their hospitalization. But my boss, like the medical director of the hospital, gets my performance reviews from the patients who rate, like, did Dr. Saiken treat you with respect? Did Dr. Saiken, courteously explain everything? Like, did Dr. Saiken wash his hands before he entered the room? Like, there are very real consequences to not having good Press Ganey scores or like good professional demeanor. Not even professional, just like chill with your patients to the point where they complain. Because God forbid, if a patient ever complains with you and tanks your score, like your boss will like make sure you know that. And like none of this actually has to do with the medicine or how well you treated that patient or how much you did for them, but like your performance and your bonuses and everything comes down to that. It's crazy.
Yeah, it's like the nitty-gritty stuff that you shouldn't worry about when you're a student or even when you're a resident as much, especially like the rating and what patients think of you. I guess maybe you should care about what patients think about you, because ideally you should be a better doctor that way. If you feel like you had a bad interaction or if a patient told you that you aren't doing so great in one thing or another. But it's unfortunately a reality. And now that we're both attendings, we are trying to, it's like growing pains getting used to that, right? Where we didn't have to think about it as much when we were in training. That wasn't the goal. It's how to be a good doctor, how to know the medicine, how to put orders in, how to do all the various things. But now that we're in the workforce, there's no more up, right? In terms of next level of training, it's all just part of our job. That's something we have to think about. And it's the reality of being a doctor in the United States and probably also in other parts of the world too.
Solar Scopes says, damn, so that customer service job I did before starting med school is going to come in clutch. Yeah, no, it seriously does. Like, this is why I recommend like all pre-meds or whatever, just like have like a random service job in college, because you're not going to be able to do it later if you go straight into med school. Like, you need to understand what like customer service means, because this is actually how people grade you in the future. And like, a lot of people think like, oh, I don't need to go work at Starbucks. Like, I need to study, like I need to study and do research and do more things. But when you actually like put those translatable skills down on your med school app or like talk about it in your essay, like a lot of adcoms actually take that into account, because these are very real world skills that maybe like your average introvert who's like awkward with people and super rude, but gets like a 528 on their MCAT and has a 4.0, they might not get into med school because of that. They'll just get into an MD PhD program instead and have free tuition.
All right, I'm not gonna throw shade to MD PhDs. They're awesome too.
Shout out to I think Tiny, who just got into her MD PhD program.
Yeah, woo! Shout out. Woo!
Camp counselor, yeah, that's a really good one too.
Yeah. Anything that really tests your patience and how to keep a calm attitude towards people who may be stressed, right? Because people who are in the hospital, they're either loved ones or themselves, they're sick. And they might not be as polite as you would expect them to, or how they normally would act too if they weren't sick or stressed. And it's something that we have to do a good job of learning how to adapt with, because there will be stressful situations. You may be in a code, like where a patient is dead and you are trying to resuscitate or revive them. and emotions can be high, right? And the nurses could be yelling at you because they think you're doing the wrong thing, or you might be yelling at them because you think they're doing the wrong thing. But at the end of the day, we have to be able to keep a cool demeanor in these stressful situations to make sure that ultimately patients get care, that they're heard and respected, and that we do the things that are right for them. And that's hard. That can take years of practice. That's truthfully why I think we call medicine a practice, right? It's because we are always practicing how to be a good doctor. And that goes for like years and years.
Yeah, Scopus also says a lot of med students I knew, the younger ones, hadn't really done a real job before. So when they start their third year clinical rotations, you can tell they haven't had to use those skills in their lives ever. Yeah, that's definitely a very real, occurrence. Like not to stereotype my international resident colleagues, but from what I heard from like some of my other South Asian co-residents, the ones that were born and raised in America, and like the stereotype that they held of the international residents, I mean, some of them, they were just told to be a doctor by their parents, and their parents supported them completely financially, with housing, and drove them to all their rotations and stuff. And they just never really knew what it was like to work in a gas station, or to have that really crappy bobarista job, or like do work study in college, so that when they actually get to like the communicating part of like working with patients in residency, like there is very much a gap between like maybe an American med student who is practicing medicine for the first time but knows how to talk to people, versus like an international resident who might not even have like a good grasp on American culture, trying to educate a patient with like a third grade reading level. So it is a very big culture gap too between like international residents and American residents coming in to the same job, all expected to start on the same foot in intern year. But in reality, like some of these people are just more qualified to talk to patients, right? They might not be more qualified on paper or have the best test scores, but they understand, just a little bit better, like what the American patient goes through, that, they will just subjectively get better scores on their reviews, right? So it has nothing to correlate with actual medicine or knowledge or anything. It just ends up being like, do you know how to talk to people? And do you know how to get people to listen without being rude, So you're saying my volunteer
Right,
with a
exactly.
hospice provider was worth it? Oh, definitely. Yeah, like being able to
100%.
volunteer with something on the front line like that, and hospice especially, like hospice is a very difficult thing to accept for a lot of patients. And even more so, like having the conversation as a provider too, right? Like I don't have like a go-to cookie cutter, spiel to give to a patient's family about hospice. Like it is still very much an individual conversation that you need to approach the family individually, taking everything into account for. Like it's not like a skill that you have that many chances to practice. And when you do, are you going to rely on the things that you learned and step up and reassure this family, or are you just going to have trouble communicating your ideas and run into a wall, and the family starts arguing with you and crying and all these things, and then you get a bad review?
Yeah, I mean, there are times where it really gets in the way of care even, right? And then you as a resident potentially, or an attending, right? You may have to reconcile two competing goals. And that's also something that you have to learn as a resident, especially is when you're attending, or when the social worker or when the hospital admin, cough, Mr. Saiken MD, is saying, hey, this patient's been staying here for too long. We need to figure out where they're going to go, or what the plan is. But the family is like, I don't know if I'm willing to make a decision yet, or if I know enough information, and I want to wait, or I want to see, I think the recovery is going to happen. I think we just need to give more time, right? You have to be able to navigate those situations. And that's not anything medical school can teach you, unfortunately. That's something that, honestly, I as a resident had a really hard time figuring out too, because it's trying to understand and empathize with patient and their family's concerns, while at the same time trying to use your knowledge in medicine, right, about outcomes or about health statuses, as well as maybe your understanding or maybe some help from your attending or from the social worker about how the healthcare system works here in the US or other parts of the world, and trying to bring that all together to come to some decision on how a patient should be taken care of, that ideally should respect what they care about, but also should keep in mind things like the cost of being in the hospital, or both money as well as the risk of infections, the risk of bad things happening, side effects, various outcomes that are not good. All those things are things we also have to balance and explain in a way that patients can understand without feeling patronized, but also within understand too, right? All these communication skills we can try to teach in medical school. I do some teaching. That's honestly one reason why I stayed in an academic center is because I teach students, I teach residents too. It's not easy, and it's not anyone's fault if you're a student or a resident, and this stuff is not easy to learn because there's no great way to teach this, right? We can have like an observed patient encounter. We can have like a standardized patient role
You can do
play
as
it.
many modules as you want, but
Right.
yeah.
But nothing beats a real person. You can't emulate that in that moment. It's only something that you'll have to experience, and definitely something that I think is helpful to keep in mind for when you start residency and even when you're in residency. Always be mindful of that and to try to learn your best for that, because those are the skills that 10, 20, 30 years down the line, when patients talk to you as a doctor and there might be like a student or a family member there, they're gonna be like, this is why this doctor is awesome because they do XYZ. And it might be you got the diagnosis right, but it might also be because you listen to them, care about them, you really understand what their worries are. That's what people sometimes say. That's a good doctor, right? And that's something that I feel like it's hard to learn.
Yeah, so all this is really to say, going back to the original, I think, question that was asked, like, it's just stuff that you're not going to be expected to learn in medical school, but it's stuff that's going to affect your practice for the rest of your life. And I think getting that kind of experience wherever you can, potentially even before you go to med school, right? Like working these customer service jobs, shadowing maybe not entirely relevant medical professions to being a doctor, but at least just putting yourself on the floor like that and understanding what this job entails, understanding what these kind of conversations even are, right? Like that will teach you the lessons that you might not use in the next 4 years, might not use in the next 5 years. But when you're in the thick of it in residency, or when you're in it, approaching that end of life conversation for like the 10th time in a week, right? Like that's going to be the stuff that gets you through it. And I talk about this in my pre-med video too. It's like a lot of your pre-med bubble friends will be like, oh, I'm taking all of these courses, I'm volunteering, 4 times a week here. Oh, I have 300 hours of shadowing a surgeon, and like I'm in 4 first author publications. But if you can't translate those skills into being an amicable person, or someone can trust, or someone who can put patients at ease, like these stats, these accolades really are not going to take you as far as you think.
Yeah. I think, definitely not something to stress out about, but also definitely something to not forget about too, right? I think going back to what everyone was talking about earlier, first steps being a resident, right? Starting out residency, the stress of that. Really, as you go through the process, ideally you'll experience all these things and more, and you may not do the best in your first impressions, right? But the goal is to not forget about those and really try to figure out what to learn from those situations. Like I'm sure Saiken as well can come up with stories of instances he's had as a student or as a resident about these situations. I definitely can. I always thought my attendings were being, back in my day when they would come up with these things. But I guess after you go through the process, you do remember these because they stay with you. And that's something that's important too, and an important learning factor.
Basically, doctors need some soft skills along with their math skills. Yeah, for sure. I mean, because like I was telling JF about this before stream, like, so I'm in an administration fellowship, right? So the things that I study and the things that I track is how do you, keep the hospital running, right? How do you keep the doctors happy? How do you keep the CFO happy? How do you keep all these things afloat to the point where like I'm doing presentations on Press Ganey scores like every month, right? And having conversations with providers who just might not be reminding their patients that they're doing the surveys or all these things, because it doesn't matter how well you do the medicine if your patients don't give you a good rating. As superficial as that sounds, like it is a metric that the hospital is tracking because that's where the money flows. And some of these, this project that I'm on is basically just analyzing risk factors, just like we would analyze risk factors for heart attacks or analyze risk factors for the development of leukemia. My project right now is like we're analyzing risk factors for why providers are not getting top box scores on their Press Ganey surveys. And it's crazy because it's such like an inversion of like all this hard science stuff I learned in, med school and residency. But this is the reality of what American healthcare is. I mean, I work in a big academic system in my state. Like, this is cutting edge stuff that people are funding because we need to be able to keep the hospital's lights on and keep the doctors, employed and not burning out. And this is what we think hospital medicine is important and will be in the future. So it's crazy that like we study this like we study diseases, and we do research on this like we do research on diseases, because patients not having good care or patients not perceiving that they have good care is just as much a part of the hospital experience as like actually treating them. So it's interesting. It's really interesting. I really enjoy what I learn. So like I'm doing an MBA, right? I'm doing Six Sigma. Like a lot of it really is kind of BS that you're just putting on the resume. And I'm okay saying that. Like I'm not gonna be a businessman, right? Like I'm not actually gonna be like a certified CEO, Six Sigma black belt leader anytime soon. But it's actually just like the actual like what keeps the heartbeat of the hospital running kind of stuff that blows my mind so much, because I've never been taught or exposed to this kind of material before. And now that you're sitting in the boardrooms and actually like understanding the decisions that people make, it's just like, oh wow, like people are actually tracking all of these things.
Right, exactly. Yeah, it's something that is absolutely necessary, right? We tend to forget about it because it's not something that patients oftentimes see. And if you're not working, even someone like me who does mostly academic medicine, working with students or working with residents, I get also ratings too every month or so about how patients thought I'm doing. And generally I'm like, okay, how can I be a better doctor? But there's something entirely different about keeping hospitals running. And sometimes it can feel a little bit like crass or nitty gritty, like the money about it, or to the admin behind it, right? People love to like poke fun at admins, or even not fun, but like be mean about it, because sometimes their priorities can seem a little bit off from what we think about being a good doctor or hospital is, right? But it's necessary. And I'm glad it's cool to hear about what Saiken is talking about when it comes to that, because it is something that is important, it's necessary. And if there's a way for us to take care of that in a way that is also going to be helpful for the patient and not forget their priorities, and that I think honestly is the best of all worlds.
I saw another comment earlier, like when we first started doing the chatting stuff. What do you think is the best part about being a PCP and the worst part about being a PCP? And then I'll do the best part about being a hospitalist and the worst part about being a hospitalist.
Yeah, that's a great question.
Like why did we go into the fields that we did?
Yeah, I think to answer it like very shortly, because I love to ramble about this topic. The reason why I wanted to be a PCP ultimately is because I want to be a part of someone's life for a long period of time. I think when I was a medical student doing family medicine, for example, in the clinic with someone who's known a patient for 30 years, right? The patient comes in and the attending is like, how have you been? How was your vacation? How are the kids? Tell me about how your life is doing, right? And maybe it is only like a minute or two, but to really know your patient and know who they are, and also to have that be relevant to how you take care of their health. I feel like that was something that was really rewarding to me, to be able to say, I've known you for years. I hear you. This is something you've always said. This is your priority. And I want to keep that in mind and never forget about that, because that's your goals. And I'm here to help you with that. I'm here to help you, live long enough to see your great grandkids go through college. Or you want to survive this heart transplant situation. So let's talk about what the next steps are there. To me, I think that was the most empowering thing. And there's nothing wrong with being a hospitalist, right? There's nothing wrong with being a surgeon who takes care of someone for a discrete period of time. And then after that, you get discharged and you might never see them again. Sometimes people like to do that too. And I'm sure Saiken will talk about that. But for me personally, that I think was the biggest rewarding thing, was to have that longitudinal relationship and really get to be like, I'm your doctor. I'm your primary doctor. and you are my patient, and I've known you for so long. I think that to me was the most rewarding thing.
Damn,
And the
yeah, like
hardest
I
things,
kind of miss.
yeah,
Oh, I guess I can do my positive first too before
yeah,
we
go
get
for
to.
it. Yeah, yeah,
Okay,
yeah,
well,
yeah.
like yeah, I kind of miss doing clinic in residency. Like as much as most residency clinics are complete shit shows, like from the admin side, from like the staffing side and everything. Like yeah, I kind of miss like following up with a patient after in the hospital, and like they bring me like a mandarin or like a peach or something and just being like how have you been, you know, and they're just like catching up with me. Like I think it's just because my patient population was a little different too. I mean, like as a hospitalist, I'm mostly taking care of like older, you know, 40, 50, 60, 70-year-old adults. But, you know, a lot of times in my residency clinic, like they would plug me in with like the 20 somethings, right? Like the college students, you know,
Yeah.
the 30 somethings, like people closer to my age. And, you know, I'd just be able to just like talk to them like they were peers and be like, hey, like, don't worry, like this scary thing happened to you. Or like, hey, this lab result is crazy, but like we'll figure it out together. All right. I'm gonna order these tests and we're gonna be chill. And you just talk to them like they're a regular human being, and you don't have to worry about how you come off. And you know, you just watch them get better over time. Like, damn, like that was such a cool feeling.
Yeah, yeah.
Now half of my patients are just like, you know, from the nursing home with, you know, acute metabolic encephalopathy secondary to UTI, and then you treat them and send them back to the nursing home. Do you think they're going to fill out the Press Ganey survey? Probably not.
Probably not. No. No.
All right. Oh,
Yeah.
okay. I mean, I would say like being a hospitalist is not convenient, but I think I like the lifestyle a lot, right?
Mm.
Like I enjoy like having all the time in the hospital that I do, and then having all the time off, right? Like
Yeah.
7 to 7, or 7 to 7, 7 on, 7 off is just such a cool lifestyle schedule. Cause it's like, yeah, I'm putting in like 84 hours a week in the hospital, and then the next week I'm putting on 0. So it's like you can do this VTubing thing. You can go on vacation every other week. Like you can, you know, do an MBA or a side gig or whatever. And like when I want to make more money, I can just pick up extra shifts. So like I was telling JF like 3 days ago, like there was like a sign up for like an extra shift that was starting at like another hospital, and I snagged up 7 of them, and that's an 8-hour shift for like 160 an hour for 7 days with a 200 bonus for picking up each shift. Like I'm literally pocketing 10K before off Kai. Like it's like there's so much freedom with what you can do with your time. Like if you want to be young and you want to grind and you want to make money, like hell yeah. Or if you want to do 7 on 7 off, you want to focus on your family, you want to be at home with your kids, like hell yeah. Like it's just like it's a downside when you might get older, but you know, when you're young, right? It's awesome. Like I have so much flexibility with my lifestyle.
Hmm. Yeah,
All right,
I'm jealous, honestly.
What's your negs?
My downside, I think Solar was talking about this a little bit in Twitch chat, but the biggest downside absolutely is the time constraints, right? And Saiken, you're talking about this too a little bit earlier when we were going through the questions about how much time that we have to really go over things, right? 15 to 20 minutes is absolutely not enough, especially if I want to be the kind of doctor who's like, how are you doing? How are the kids? How was vacation? Right? That's like 1, 2, or 3 minutes gone. And that's the time I could have spent talking about your diabetes or your colon cancer screening or your blood tests or whatever it may be, right? I wish I had more time. I wish I could have longer appointments. Sometimes I finagle it. Sometimes for patients over the age of 80 where I work, I can justify getting them 2 slots to do a 40-minute appointment. And that's like a world of a difference, because patients that old generally have a lot of medical issues, and I need that extra time to really actually go through them in detail and not feel like I'm being rushed. But you know, for most other patients, 20 minutes, absolutely, it's been something like a relic from the old days of primary care, unfortunately, and hospitals have kind of stuck with it because it's an expectation, and it really is not enough. I'm always late, and I try not to be, right? But because the biggest problem about being late, and sometimes patients don't always understand it, it's not their fault, right? But if I'm, for example, taking 5 extra minutes for you for this slot, next patient's going to be 5 minutes behind, and I either have to cut their appointment 5 minutes short, or if I go the full time, the patient after that would be 5 minutes behind, right? And if it adds up, every patient I'm like 5 minutes extra to like talk about how they're doing. By the end of the day, I'm like an hour behind, and this person's been waiting an hour plus for me, and that's not right, right? So if I could fix something about primary care, 100% would be the time constraints. It's just something I have to learn to deal with, and I'm trying my best to, right? Whether it's doing more what we call inter-visit care, where it's what I feel like doctors could do more of, but it's a lot of work. Where, for example, I call you after my clinic is over to talk to you about test results, or you called me earlier in the day and I couldn't make it because I was busy. Well, let me call you back now because I've got time. I feel like patients really appreciate that because it feels like their doctor is approachable. It feels like their doctor's responsive, that if they have a question, no matter how insignificant it might be, if I got the time to answer it, it's not too much skin off my back to say, here's my response to that. But it adds up, right? If I have a panel of 400 patients, which I do, unfortunately, and like 100 of them a week respond with a question or call me or something like that, that's why I'm oftentimes on Epic on my medical record doing work at 9 p.m. on a weekday, because I'm trying to finish all my stuff so that I don't have massive workload debt at the end of the week that I have to fill out and finish.
But that's pajama time, isn't it?
That's pajama time,
like
exactly.
You're not getting compensated for your work then.
Unfortunately not. And
I will say, like, the reason I like working swing shifts is because I do get paid overtime also.
Yeah, it's something I'm jealous about. I do my best to be like a really proactive primary care doctor. I feel like my patients, at least the feedback I've heard directly from them, they appreciate it a lot. And it makes me feel fulfilled and happy because that's what I want to do in primary care. But Saiken's absolutely right. I don't get paid extra for it. It's something I do out of the kindness of my heart because I want to be a good doctor. I hope I will continue to do this 20, 30 years later, but my fear is that I will burn out or I'll feel tired or something will happen. That's why primary care people do get burned out, because it's a very demanding position.
So if, you think it's like you're spending a lot of extra time trying to do the most for your patients, and you're also not getting compensated fairly for that time, would you ever consider doing concierge medicine?
Me personally, no. And the reason why is because I've interacted with concierge PCPs before when I've been on service, because I do also do inpatient medicine a tiny bit for residents. Very negative experiences. Nothing against the doctor I talked to. But this patient, I actually told Lev about this patient, and I don't know if you heard about this, but I'm happy to tell you offline. But this patient had a lot of comorbid medical and psychiatric conditions. The punchline is I was concerned that she may have factitious disorder, Munchausen syndrome.
Oh yeah,
and
you kind of talked a little bit. Yeah.
And to cut to the chase, she had a concierge PCP who was signing off on everything.
And just like
he was signing
it?
off, basically, because he got paid for it. Like the more he signed off, the more he got paid. And I'm like, I hate that. Like that's not doing the patient a service. That is harming the patient because you're getting paid.
Well, I mean,
and I don't want to ever become that person.
But like, I don't think you would. I mean,
that's
like,
fair.
I don't think automatically going concierge is just going to mean like, 10 years later, you're going to become like a profit-minded, factitious disorder imposed on patients, like kind of guy. I mean, because it is like a legitimate career path for a lot of people where you're able to provide the care that you personally wish for a lot of patients, just, for a certain subset of patients, right? Like, but does it just like disagree too much with your ethos of medicine or personality?
I think it's part of it, right? Like I say, Flinker, I see you're in YouTube chat and you're saying, what about populations where concierge is the only option? And I think ultimately concierge as a medical access is not inherently bad, like Saiken was saying, right? It's not inherently evil. There absolutely is the option or potential for people to take advantage of the system. But if concierge medicine is the main way you can get medical care, I've got no objections to that. I think personally, it did give me a bad impression of it. That's totally fair from my perspective. The other thing I didn't bring up too is, one of the other reasons why I ended up staying where I am, which is in an academic center. It's like like Saiken is also in a big university level hospital system, is because I love teaching. I love teaching with medical students. I love teaching residents. Don't think I would be able to do that as a concierge PCP. At least for the time being,
rotation,
right? It would be for the students and the residents, right? But like, Part of what gives me fulfillment and joy in being in the medical space is to be a teacher. And I'm truthfully, I'm an assistant professor in medicine. I do teach. I have that title because that's what I want to do. It has its own detriments, absolutely. But I do love teaching, and I think that's one of the reasons why I'm in the position I'm in. So maybe in the future, I'd be doing less primary care because I'm doing more teaching. That could be something that I might do. I'm not sure yet. Um, but I think concierge is a little bit just out of the way from that natural progression. I just don't think it would be a good fit for me for non-medical things too that I like to do.
Mm. Oh, right. The negative. Yeah. I think I tweeted about this the other day. I mean, I just had a rough day at work, like, with a certain case, and sometimes, like, as a hospital doctor, like, you're getting patients at their worst, right? And ultimately, you're not going to be able to have a good outcome in every case, right? Like, it's the reality that in your clinical practice, patients are going to die. It just sucks when you do everything you can and it doesn't change the outcome anyway. I guess I wouldn't say the outcome, but like it doesn't change the end result. So the lesson that I tweeted, it was like a clinical pearl from the intensivist that we had at our residency hospital, and Hito also commented on this because we did residency together. But the intensivist told me, he's like, we don't save lives here, we control outcomes. And if you wanted to save lives, like, you should have done primary care, right? Like hospital medicine, or especially ICU medicine, like he did, right? It's very difficult to say that you're going to make a patient better just because you don't know if they're coming in from like a nursing home with very poor care, with uncontrolled chronic issues, 3 or 4 uncontrolled chronic issues, or you're just going to have like a 35-year-old with a kidney stone coming in, right? And sometimes patients are absolute train wrecks, and I'm able to bring them back to life, and that's an amazing feeling. But sometimes patients just have 2 or 3 issues and they're too far gone at that point, that all I can really do is call the family and like ask them, like, what do you think is the most appropriate option that grandma would want? Or has your uncle ever talked to you about like a will, or what his advance directive or these wishes were? And it's not like a helplessness, it's just a very somber moment that keeps happening, right? It's
Right.
just the reality of working in an acute care setting, right? You're going to have people that are healthy and get knocked down a peg, or you're going to have very poorly controlled patients that their version of getting knocked down a peg is, I have to put you on hospice in the hospital and watch you pass away 2 days later, and I have to call your family by phone because they're in India and they can't get here for 3 days. Like that part just still stings every time it happens, right? Like if you're in a
Right.
PCP's office, you're in an office, like patients are coming to you, right? Like they are still in a position where they can drive or get driven and sit up in your office and talk to you and stuff. Like, yeah,
Mhm.
the reality is I'm not afforded that every time. And sometimes, no matter what cards I'm dealt, and no matter what I try to do with the cards, like, the outcome is always going to be poor. So it
Mhm.
sucks. I
Mhm.
mean, that also is probably our version of burnout, right? Like, just so many poor outcomes. Like, our population is only getting older, right? Our population is only getting sicker. um,
Right.
we will probably reach a critical mass with inpatient medicine, in the next 15 years, 20 years or so. So, I mean, like, yeah, on a grand enough scale, that's why, I like to do what I do as saiken, right? Like, talk to you guys about this kind of stuff, like, teach you guys about, different things, and like, try to make an appointment with your doctor. Like, even if you're 25 and healthy, like, at least have a PCP, right? At least have like a name that you can give someone if like the EMT finds you collapsed on the road, and like, they ask you who's your doctor and they can send you to the right hospital and everything. Like, life comes at you pretty quickly, and like, as much as I like to say, like, yeah, these poor outcomes only happened in like 82-year-old nursing home residents, I mean, sometimes it's like a 40-year-old like young dad, or like a 38-year-old new mom, and they're, having these end of life conversations very quickly from, when they were completely healthy like 2 weeks ago. So yeah, that sucks.
Yeah. Yeah. I mean, the same thing. I'm with you there, especially if you can imagine being the PCP for a patient who's like that, right? Who bounces between the nursing home and the hospital, and they can't make it to the primary care office because they're so sick. I've taken care of my population. Truthfully, my patient population. To answer Flinker, I saw Flinker's other question there about kind of academic center primary care versus like community primary care. It's interesting in the sense that patients who are more medically complex generally are around areas where there is higher level of care, but not always, right? Access is definitely a struggle, especially in rural areas. But for my patient population, we're specifically in like a very underserved area in a large city in the US. So these patients have usually many medical issues. Like I think on average, my patients have like 6 or 7 chronic medical issues. And I've taken care of people with like 20 issues. My note was like super long because I would try to go through everything as much as possible, and it was tough. But a lot of these patients have to go to the hospital very often because they just have a lot of chronic issues. Their health reserve is very low. And if something happens to them, they catch a cold, get a flu or something like that, they're probably going to end up hospitalized. And as a primary care doctor in that situation, it's also similarly very distressing. You're like, what can I do? You can't make it to the clinic, right? I can try to call you. I can try to go to the hospital and visit you, which I've done. I've gone to the hospital where they're hospitalized to go to the room as a visitor and just say, how are you doing? But it's hard to advance care that way when patients aren't able to come to clinic, when they don't have that ability to or that luxury because they are so sick. It's tough to try to bridge that gap between where saiken works and where I work. And I feel like people there oftentimes get lost because they don't make their appointments because they're always in the hospital, but then they need someone to come to the hospital who knows them to take care of them because new hospitalists might not know who they are or their medical conditions and how to treat them best. So there's like many facets of this too, both on the hospitalist side where saiken has to deal with patients who are like that, who you can't do a particularly fulfilling job of because they're so sick. You're basically plugging holes in a sinking ship. And I don't want to leave that analogy for people's health, but it can feel that way, especially for someone who has a lot of medical issues or constantly facing acute flares or episodes or exacerbations and things like that, like some of the patients we took questions for today in our examples. So yeah, it's pretty complicated, both access to care, where we work, how we work, the patients that we see, and what patients have access to. People make an entire career out of that with public health and with community health and everything, which unfortunately I can't speak much more about, but it absolutely is a big deal for a lot of people.
Yeah, I guess to make this like a happier note. So
Yeah,
like
please do.
so I did residency in like not like a rural area, but it was like a smaller city, maybe like an hour and a half from like the capital of that state. So it was like a small, like pretty there was a university, I think, but it was pretty much like an aging population, like poor socioeconomic status in the South. My patients were like mostly high school level educated, mostly like earning below the poverty line. But like some good things that we were able to do was community outreach, and just being able to do these small things, kind of like what I tell you right now, like as saiken, but like small volunteer activities at like churches, at fairs, going on like the local TV station to talk about like sunblock and skin cancer risk and stuff like that. Just even being able to do like these little small things that we thought were kind of silly because it's all like common sense to us at this point. But, just being able to, take a grandpa's blood pressure at church and then being like, hey, like, has anyone told you you've had high blood pressure before? Like, please follow up with us, like make an appointment with us, like try to do, something because this can be dangerous. And then, actually getting a new patient caring about their health because of that. Um, like I kind of miss that community outreach aspect because it actually like let you see kind of the fruits of your labor where like your public efforts were helping at least a certain like population. Like we weren't going to like the country clubs and stuff, but we were doing our best with what we had to like people who, still deserved it, right? So that was always really cool to see.
Yeah. Yeah. Our med school too had like free clinics in honestly in like people's homes or in like the local church or the library where medical students, these are like first or second years, would really take the lead in like recruiting residents or even recruiting attendings to be like, can you help us set up a clinic in this house or in this place? For people in the community to come by and say, hey, doc, I've got a stomach ache. Can you check out what's wrong with it? And you might not have a CT scanner, you might not have like fancy medicine or equipment, but you can take a listen to their stomach, take a history, and do some medicine, and then either reassure them, yeah, this is probably, I don't know, reflux, acid reflux or something, or you had a stomach bug, or you ate like some food that was like 7 days too old or something, and give them reassurance, or say, hey, you should probably go make an appointment with your primary care doctor because I'm concerned this is something more serious. Just having the ability to give people who might not have that access to medicine the ability to get some advice about their medical care in the community close to their home, like down the block. I think actually one of the free clinics I volunteered at as a med student was 2 blocks away from where I used to live as like a 3-year-old in the city, because I've stayed where I've lived roughly for a long period of time.
Whoa.
And
Wait, I didn't know that. That's crazy. Wow.
yeah, no, it was really cool. And I would like, I got off the bus to go to that person's basement, and like across the street was the school, the elementary school. That was my bus stop when I was a kid. And I'm like, I think my house was like down the block over there, or like the place I rented from, because my family also was not doing so good at the time because my parents are also immigrants too. And to me, that was super cool. And honestly, now roughly, how long ago was it now? Like 6 or 7 years later? It's been a while, but 6, 7, totally killing the mood there. But like one of the faculty members who's sponsoring the free clinic was like, hey, JF, we know that you used to grow up there. Do you want to become a faculty sponsor and like go there as an attending now to like help the students with this community clinic? And I'm like, that sounds awesome. Yeah, I would love to do that. So it is, like Saiken saying, it is really awesome to do that. It is unfortunately something that absolutely have more presence in many different communities, but yeah, it is very nice.
We got a Twitch raid from Ray Chu and friends. Hello, everyone. You're kind of catching us on like the sleepy end of this stream, but my name is Saiken MD. I am a Dr. VTuber, internal medicine doctor in real life. Today, joined by JFMD, also Dr. VTuber, internal medicine doctor in real life. We were doing board review questions because we both took boards last year, and we were thinking, do we still remember all of the exam stuff? And we did. We got 15 out of 15. We were doing pretty good. So now we're just chilling, talking about our jobs, talking about our lives. Yeah, we're just hanging out right now.
We're just vibing.
We're vibing, talking about how different practices from school, how important it's to do customer service before just jumping to be a doctor. Talking about the best parts of the job, the worst parts of the job. I don't know what else is important that you think people should know.
Yeah. I guess I think for patients too, because, not everyone goes into medicine, but everyone absolutely at some point in their lives will probably have to be a patient for themselves or a family member who's a patient, right? I think, Saiken, in a lot of your content you talked about, which I think is very helpful and important too, is the importance of advocating for yourself and for your family members or whomever you're caring for, right? And I think part of the tidbits about that, I feel like, especially as a doctor who works a lot with that in the primary care setting where a lot of this happens, and I'm sure on your end too, as the primary in the hospital, right, where patients oftentimes are the first to tell you about something like that. I think what's helpful for people who are not medical professionals in that situation or healthcare workers is to really have an effective way of being an advocate, right? And I think this also goes a bit into the customer service kind of side of things, where being an advocate, being the best advocate might not be yelling at the doctor who might be stressed, overworked, or tired, or whatever it may be. At, hey, you haven't seen my mom yet. What's going on, right? But more so being aware of things, being the eyes and ears at home for your doctor who may not know about these things, and talking to them about these things, right? Um, there was a patient I took care of who I didn't know what was happening at home. It's hard, right? You don't live with the patient. I always tell my patients, I don't live with you. I'm not your mom, dad, brother, sister, whatever it may be, family member. I can't tell what's going on. You have to tell me, or someone from your family has to really give me the best picture about what's happening, because that stuff's important, right? And I'm sure in the hospital too, especially when someone gets admitted. But part of the challenge I found, especially with some of my colleagues who are further down the medical career and they might be getting burned out, or they might be busy or overworked, is if patients bring up something like that, it's like a gut reaction sometimes to dismiss that, or to just be like, that's not maybe that medically important. I don't really want to take the time to talk about it, especially in primary care where time is usually pretty valuable. And some of the times I feel like when patients are very stressed, or when family members are very stressed, like we talked about earlier, it can be natural and absolutely understandable to be upset and to be frustrated and to have emotions run high. And I feel like that can make things harder for you or the doctor or everybody, right? Everybody might get upset. Everybody might get frustrated, and no one's going to be happy. And that's something to keep in mind, both as a doctor, right, to try to diffuse the situation and to navigate that, but also as someone who's trying to advocate the best for yourself or your family member, right? If you can tell emotions are running high with your doctor, your nurse, your healthcare worker, that probably isn't going to help the situation either, because we're also all human, unfortunately, or fortunately. And I think that's an important perspective, especially as someone who's trying to navigate both situations. People who have done their best to be like, here's everything I've written down, doctor, I'm trying to be helpful. And I'm like, thank you so much for doing that. And also family members where they're like, doctor, no offense, but why are you an hour and a half late? Like, I had to admit somebody because they were dying. And if people are understanding, that's great. I'm very gracious about that. Patients are not understanding. I get it, right? It's not their fault, but also it makes the interaction more challenging. I feel like there's some nuance about it too, especially having gone through the process as a PCP or as a doctor does that a lot.
Yeah, I'm gonna echo what you said on like symptom diaries and like symptom journals and stuff, because like I think there's so much negative stigma from like the patient end. They're like, oh, like I don't want to bring this in and like waste the doctor's time and whatnot, right? Like I don't want to seem like I'm backseating the doctor. But like as you guys saw, like in the question stems that we did, like more information is better than less information, right? Like if it's a waste, I will parse through it and realize it's a waste, and I will know that it doesn't impact my clinical judgment. But like if you're able to trigger like your episodes of migraine with A, B, or C, and you write it down each time and show me evidence like, oh, like this happens when this happens, or this happens when this happens, like it only gives me more information to make the correct diagnosis. Like patients who stay involved in their medical care and are bringing up ideas or bringing up like different possibilities, like at least it gives me a sense that they care to like make a change, or they care enough to look it up. And especially like older patients, like even if they're just throwing their diagnosis into AI, or like giving me like a chat GPT printout, or just like being like, doc, like I read on Wikipedia, like blah, blah, blah can happen. Like, yeah, it's not great information, and I'm going to clean up like the misconceptions that they have, but at least it shows me that they're involved about their condition, and like they are caring enough to like want to make it better, right? Like there are so many patients, I've taken care of, and you've probably taken care of too, where it's just they just accept what it is, and they take the medicines that their doctor gives, and they get to the hospital when they don't feel well, and they ask like, did you take your medicines? Like I don't know, like my wife gives me the medications, or
Right.
like I just give whatever my doctor, it's in my chart, blah blah blah, right?
Yeah,
And
exactly.
the difference between somebody, like they don't need to be right, but I just appreciate it when patients care enough to know like, oh, okay, I take this. It's like a purple pill. I don't remember, like, does it sound familiar? And then I give them like a few things. Like, at least it shows me that they want to get better instead of just like try to just let the system, do its job. Obviously, there's a bias towards younger patients here, but I would say like advocating for yourself and just trying to stay involved with the conversation is probably one of the most like reassuring things I see in a patient that I'm about to take care of, because I know that like even if you don't agree with like my management, like I have the chance to like talk to you like through like why I'm doing things this way or why another doctor might do things this way, and we can actually like have a dialogue about how your medical care is going, right? Like, and as much
Yeah.
as that is true, like I mean you should feel like you're in a safe space with your doctor to question like how your care is and like why things might not be getting better, and get an answer that's not just like, oh, it might just take more time, or like, oh, like we'll just keep doing this for another 6 months, or blah blah blah, right? Like I want patients to be more involved, I want doctors to be more involved, I want people to just be more inquisitive and comfortable being inquisitive. And I really hope like with like a new generation of patients that are going to be seeing their doctors more often, that like we kind of change the stereotype of just doctors like doing paternalistic medicine, and patients just accepting it, or patients like being stereotyped as the people that just argue with everything, and the doctors just like say, okay, fine, like I'll give you the Percocet or whatever, right? Like I really
Right.
wish
Right.
like we just have more dialogue between patient and provider.
Yeah. I mean, I'm also hoping too with newer generations of doctors that our mentality is slowly changing, right? Because I think one of the things that you talked about in one of your videos about alternate medicines, right? Herbal supplements, things like that, is something that I personally think is important for patients to be truthful about, like you talked about. Um, but I think it's hard because for a long time, doctors are always like, "Oh, that stuff doesn't work." And I think even today, you might experience a doctor saying, "Ah, it's garbage. It's not going to work. Don't waste your money on it." And I feel like that kind of dismisses the patient and what they're thinking about when it comes to that, right? They're taking their health proactively and saying, "I heard about this being potentially useful, garlic, or this particular herb, or this thing. Maybe my family showed me this. My sister texted me this. What do you think about it?" Right? If a patient is being proactive and truthful enough to say, I started taking this, or I'm thinking about taking this. What do you think? Right? We should not shoot that down. I feel like that definitely doesn't help the doctor patient relationship, right? And if it ultimately doesn't harm the patient, my philosophy towards that is like if it's not unsafe for you, if I can check a database I've got that's thankfully very helpful. I have a database about like non-prescription alternate medicines where I work, and I can look up like the interactions with prescription medicines, and I can tell a patient looks like it's safe to take with your prescriptions, and there's no concern for toxicity or anything harmful. Then I'm like, go for it. If you want to do it, if you already spent the money, or if you think it could help you and it's not going to hurt you, I'm not going to say no. I'm just going to try to make sure that it's safe for you, right? Also, that harm reduction that you've talked about before in your past
Harm
content as well,
reduction.
right? Harm reduction, the buzzword for people who focus on addiction medicine and especially in recreational substances, right? It's like it's not about saying no. It's not about banning something, right? Because it's dismissive and ultimately it's not going to get rid of the behavior either, right? And it disregards like why people do things in the first place. But ultimately, I think it's closer to what doctors should be doing, which is above all else, it's the health and safety of our patients. That's what we care the most about. We can't control you. I can't control you. I can prescribe a medicine and you can choose not to take it. And that is absolutely your choice. I can't make you take that medicine. And I feel like if I were to just like shove a prescription into your hands and kick you out the door, it's probably going to make you feel less trustworthy of me as your doctor, right? I didn't listen to you. You said you weren't going to take it, and I didn't respect that. So, if I get graded, like Saiken was saying, on quality metrics, like, do my patients have controlled blood pressures? Do they is everyone on a statin? The answer is probably going to be it's worse than other doctors I work with, because personally, I'm like, if you're not going to take the medicine, why should I prescribe it to you? It's not going to be helpful for you. You might distrust me because I'm trying to ram through a medicine, or that might be your perspective of me. I don't want that, right? If we can come to some agreement about how you want to approach your health, then that to me is more important. So, kind of similar to kind of what you talked about before in your past videos.
Yeah. That one blue says, "Hey guys, love the stream and the work. I've been wondering, why did you guys choose IM over other generalist specialties like EM, FM, PEDS? Did you know you wanted IM as an M1?" I wanted to be a dermatologist. And then I realized I did not have the grades to be a dermatologist. um I did IM because I enjoy like the generalist aspect of it, right? I enjoy knowing a little about a lot. And like if I don't know the answer to something, I have somebody to be able to consult about it. But, you know, unless I need like a procedure or I need like a surgery done on a patient, it's really just like I am responsible for your entire continuum of care. And like I can take care of this issue, this thing, and I'm not just limited to one area. Um, did you know you wanted IM as an M1? I feel like I see you as a cardiologist.
Really? Is it because of the journal clubbing?
I mean, it's just because of the. I mean, it's where you went to school. It's the journal clubbing.
Okay, don't say that. Okay. I truthfully, the theme for my entire like medical career up until residency really was I had no clue what I wanted to be, and even like I decided what I wanted to do, which is I am final answer, like the July or August of fourth year of medical school when we were applying for residency was when I was like, all right,
Really?
yeah.
Wow.
Because I mean, I was choosing between a few similar options, and I think this is potentially similar to a question that I saw earlier in chat too, was between family, IM, med peds,
Oh yeah.
and right, all of them can be outpatient facing primary care professions, right? So I think when I was an M2 or M3, that's what I had the idea of what I wanted to do. So I think primary care for me, pretty early on, I was like, that sounds like something I'd like to do for the reasons I already said. But you can be a primary care doctor and see kids only and be a pediatrician, right? You can do family medicine, see everybody, right? And you can be med peds and also see everybody. And med peds might be like a specialty that's less familiar to people outside of the US, where it kind of, you do like a double, almost like a double residency where you do both IM and peds in 4 years instead of 3 years for each. And then you can get double boarded for both and see both kids and adults in both like the general primary care sense, but also in like the specialty sense. So if you wanted to do like adolescent endocrinology, where you saw like people who were at the cusp of being an adult, but also like a late teen, then you could be professional and do that. So that to me was kind of attractive because I was like, I don't know what I want to do. Maybe that I want to do that. But I think to kind of get into the weeds about what's so different about each of those, right? Family is more so specifically outpatient, and the training reflects that in residency, where you do pretty much entirely clinic. You don't do any inpatient medicine at all, which is dramatically different from IM
Medicine.
residency, where
Yeah.
you do a lot of inpatient medicine and much less ambulatory clinic. And it limits your options too, because you really can't do as much, if any, inpatient medicine as a family medicine attending. You can. I think where I work, there's like 1 or 2 family medicine attendings who've earned the privilege to be a hospitalist sometimes. And I think in the countryside and rural settings where access is less available, it's more common potentially to just have like one single doctor who's both in the hospital and out. But it's definitely not the norm in big urban centers where there's a lot of doctors around, because you have specifically hospitalists like saiken who only take care of people in the hospital, and then people like me who only take care of people out of the hospital. Why should they hire someone who can do both? You stretch thin, right? And I think that uncertainty for me was like, I don't know, do I want to do cardiology like saiken joked? Do I want to do endocrinology or any other specialty that's medicine, like that's in the body, that I would only learn if I were to do IM? And could I lock myself out of that if I chose family? So that was the reason why I was like, I don't think I want to do family, but med peds was also an option where I could do it. The real wake up call was when a pediatric attending, who was actually one of our advisors for applying to residency, was like, look, JF, are you just going to be a glorified family medicine doctor? She said it, she was a little bit rude, but she was being honest, right? She was
Damn.
like, are you just going to be a glorified PCP after doing 4 years of med peds residency? If that's what you want to do, don't do med peds. Just because you're not going to have a fun time and you're not going to get anything extra out of it. And I thought about it for a while and I was like, you're right. It's a wake up call, but it's true. So that's ultimately why I decided IM. I think the versatility of what I could be. You could be a cardiologist if you wanted to, if you weren't sure, right? You can do preventive cardiology, where that's a lot of what I do in primary care is how can I lower your risk of heart disease? That's kind of something we do all the time. You can really just hone in on that and say everything else, the colonoscopies, the breast cancer screenings, everything else, talk to your PCP. I don't want to deal with that, right? It gives you that ability to do that. But I really wasn't sure up until almost the end of medical school. It was a decision that I feel like was not easy for me.
So what made you not choose EM?
Yeah, I think EM was tempting because it is a lot of times shift work, right? So it kind of fixes the concern about like doing work after you go home.
Which is what I like as a hospitalist, yeah.
Yeah, exactly. I think the issue with me and all of the med students where I went to med school, we do an EM rotation fourth year of medical school, so all of us go through it. I think the issue with EM for me was partly the burnout, especially when it comes to taking care of pretty complex patients and not having the resources to deal with it. It might be specific to where I work and where I trained and where I went to medical school. Our EM is unfortunately very short-staffed, very under-resourced, because the truth is emergency departments don't pay the bills in most hospitals in the US, right? Because of EMTALA, which is the federal law that stipulates anyone who comes to the emergency room for a hospital must be triaged and they must be stabilized. You can't turn them away if they don't have insurance, right? So people who, for example, get into accidents, who get gunshot wounds, who get very injured, who need a lot of care, right? Those patients need a lot of care to be stabilized. That costs a lot of money. The ER is required to take care of them, right? So because of that, hospital systems are like, you don't pay the bills, we might not give you more funding because even though you're important, we don't get the return on our investment to do that. So the place where I trained at, our ER was definitely like that. We were like a third of a parking lot building. Like there was like a multi-story parking lot and we were like a third of that building as the ER. And I'm like, this is not enough space for the people here. Like the waiting rooms had like 100 people waiting.
Yeah.
The people were in like
for there, yeah.
In the hallways, right? Exactly. And I'm like, this is miserable. I feel awful for the patients who have to sit through all this. And I feel awful as a provider here because I feel like we could be doing so much better and we can't. So that was one reason why it was a more personal reason why I worked, but that to me turned me away from EM. And I didn't really want to try to experience other experiences. I kind of decided by then.
Okay. Bill's Potato asks, hi doc, what's the difference between general physician and family med specialist in the range of medicine that they can practice? Yeah, so like I think the translation was like the nuances between family medicine and internal medicine. So like internal medicine is more like the hospital medicine care. It's more of like an academic specialty where you can go more in depth in the different medical subspecialties like cardiology, gastroenterology, endocrinology, etc. But it's about like 80% hospital training, 20% like clinic training, and you only see adults. Like you don't see children, anybody under 18. So in contrast, family medicine is more like 80% office-based medicine, 20% hospital-based medicine. Family medicine has a lot more training in like primary care issues. So like they have more psychiatry training than we do, more OB-GYN training that we do. And family medicine is a bit more broad in terms of the office specialties that I can work in, and things like sports medicine or, I guess like sleep medicine or something, like a lot of like interdisciplinary specialties. But ultimately, like those are specialties in terms of training. At the end of the day, an internal medicine doctor can work as a primary care doctor in the office like JF does, or a family medicine doctor can work in the hospital as a hospitalist, like I am. So, I mean, it's just two different paths. The training is a little more robust in one area compared to the other when compared to the other specialty. But it's just like, do you want to learn more about the adult medical world and, the different conditions that affect adults, like, in their 60s and 80s? Or like, do you want to see everybody from like 1 month old until like 60 years old and like everything in between that includes with that? So.
Yeah. there's a little bit too of a difference that you don't learn about unless you apply for a job, which I did recently as a general practitioner or a PCP, where I think the main distinction is like as someone does IM residency, you have more exposure to medicine concepts, right? As you know, you might rotate with a cardiologist, you might rotate with a liver doctor or a lung doctor, and family medicine doctors don't get as much experience with that in their rotations because they're more focused on the things that Saiken was talking about earlier, psych, family medicine, OB-GYN, delivering babies, for example, that I won't ever get experience with, right? As adult I am. But then that translates to, you know, if I'm in clinic and I have a patient who has potentially like cirrhosis of the liver, right? Like fibrosis of the liver or something like that, I could potentially take care of that myself. And I personally do, right? Like I can order a fibroscan, I can do an ultrasound, I can like calculate scores, I can like figure out, they can certainly learn these things too. And there definitely are family medicine doctors out there, I'm sure, who are comfortable with these more advanced medicine topics, but it may be a bit more out of their scope compared to what they're used to doing, like sports medicines, injections for the knee, for example, for arthritis, or delivering babies or taking care of kids and things like that. Just in like different training leading to different skill sets and expertise.
All right, it's it's getting kind of late here. I know a lot of people have like more questions and stuff. So I guess just to plug myself, or actually both of us. I mean, JF and I will both be at OFCAI next month, and we're both paneling. He'll be doing a talk on parasocialism with Ichikemaya. I will be doing a live version of my office hours Q&A thread. So, I mean, if you guys still have questions, you know, different things about medicine or just the field that you want answered, I'm going to be putting up like a AMA thread on probably Friday or Saturday this weekend. And I'll just be collecting questions from the community, like stuff that you want to ask your doctors, or, you know, different medical anomalies, like what's the coolest case you ever diagnosed, or how does, you know, ibuprofen work, or like why are migraines a thing, and that sort of stuff. I will be collecting all of those, making like a presentation, making a panel out of it, and I'll be presenting that at OFCAI on, I think, like it's like the Sunday, the day 3 of that convention. And then in the same room, JF will be there doing his talk like an hour later.
1 hour after Saiken, I'm doing my talk on parasocialism. And I think Maya and I will actually be releasing a survey as well, like a questionnaire about examples of parasocialism or observations of parasocialistic behavior that you've seen in the VTubing space as VTuber viewers, or potentially even you VTubers yourselves, right? And potentially we'll be talking about that in our panel. And the overall theme is kind of how does it relate to health, right? Especially with concepts of like loneliness and lack of social connection and isolation that you may have heard about, that's growing as an increasing problem in our society and also just in the world too. So if you're interested, please check it out.
Cool. All right. You wanna do a sign off? You wanna get out of here?
Will do. All right, everybody. Thank you so much for being here with us today on both our boards review as attending medicine doctors, and also with a bit of chit chat at the end, questions about how 2 doctors are doing. My name is JFMD. I'm your medicinal plant dragon VTuber question mark, maybe soon TM. And Saiken, thank you so much for having me here today.
Yeah, no, I just think it's so funny, just the juxtaposition of this between having Bree and Nazumi on stream the last time I did it. So yeah, no, great time. Obviously going 15 out of 15 feels good. At least I remember some things from residency, 15 things from residency in my current practice. So yeah. Oh, wait, I gotta plug the Discord. Dude, the last time I posted the Discord in the chat, like it got so many like invites that like it had to lock it down because it thought it was being spammed. But yeah,
you're so popular, Saiken.
I don't know. It just happened out of nowhere. All right. Did my model freeze? Oh, my phone died. Oh shit.
We've been going for that long.
Oh my god, hang on. Can I use my webcam? Oh fuck.
Uh-oh.
Okay, we're good. All right. Yeah. So I will maybe try to stream again this Saturday. I'm non-clinical this week, so I'm kind of chilling, but I got things to do. So we'll see y'all then if I see you. But yeah, I hope everyone has a good night and stays healthy. Goodbye, everyone.
Take care, everybody.